Welcome to Wound Care Assessment and Management, integrating AI tools into clinical practice. Chronic and acute wounds are a major and growing clinical challenge across every healthcare setting, affecting millions of patients each year and placing a heavy burden on healthcare systems worldwide. Diabetic foot ulcers, pressure injuries, venous leg ulcers, and surgical site infections account for a disproportionate share of morbidity, prolonged hospitalizations, reduced quality of life, and healthcare spending. Wound healing is governed by interacting physiological processes, including inflammation, angiogenesis, epithelialization, and tissue remodeling, and that complexity demands that clinicians bring a deep understanding of wound assessment, evidence-based management, and the impact of patient-level comorbidities on healing trajectories. Two converging forces have reshaped the wound care field in recent years. First, an expanding evidence base has sharpened our understanding of validated assessment tools, etiology-specific management strategies, and the critical role of interprofessional collaboration in optimizing patient outcomes. Landmark guidelines from the International Working Group on the Diabetic Foot, the American Diabetes Association, the European Pressure Ulcer Advisory Panel, and the American Heart Association have set new standards for risk stratification, prevention, and treatment. Second, the emergence of artificial intelligence and digital health technologies has introduced first-of-its-kind capabilities in wound diagnostics, treatment planning, telehealth delivery, and remote monitoring, offering the potential to improve clinical accuracy, expand access to specialized care, and reduce healthcare costs. This course is designed for physical therapists, occupational therapists, nurses, and all applicable allied health professionals who manage wounds across inpatient, outpatient, long-term care, and home health settings. Over 7 content modules and a detailed case study module, you'll progress from foundational wound assessment and classification systems through etiology-specific management, dressing science and nutrition, comorbidity impact, AI-powered diagnostics, AI-driven treatment and telehealth, and interprofessional roles in wound care. The course draws on current evidence from systematic reviews, meta-analyses, randomized controlled trials, and clinical practice guidelines published predominantly between 2022 and 2026, so you're engaging with the most current evidence available. Each module is grounded in the source literature and supported by liberal in-text citations mapped to a unified master reference list. 5 integrative case studies pull knowledge together across modules, challenging you to apply assessment strategies, evidence-based interventions, AI tools, and interprofessional coordination to realistic clinical scenarios. By the end of this course, you'll have the knowledge you need to elevate your wound care practice through evidence-based assessment, advanced therapeutic strategies, and the thoughtful integration of artificial intelligence into clinical workflows. Upon completion of this course, the learner will be able to: first, identify validated classification systems used to evaluate diabetic foot ulcers, pressure injuries, and venous leg ulcers. Second, compare evidence-based management strategies for common chronic wound types and surgical site infections. Third, select appropriate wound dressings and nutritional interventions based on wound characteristics and patient factors. Fourth, differentiate how obesity, peripheral artery disease, diabetes, and chronic kidney disease impair wound healing. Fifth, identify the clinical applications and limitations of artificial intelligence tools in wound assessment. Sixth, evaluate the evidence supporting AI-driven treatment recommendations and telehealth wound monitoring on clinical outcomes. And seventh, analyze a clinical wound care scenario to determine appropriate assessment strategies and evidence-based interventions. Let's get started with Module 1, Foundations of Wound Assessment, Validated Tools and Classification Systems. Thorough wound assessment is the foundation that all effective wound management is built on. Standardized, validated assessment tools help clinicians communicate clearly, predict clinical outcomes with measurable accuracy, and guide treatment decisions across the continuum of care. But the value of structured assessment goes well beyond the initial evaluation. Serial reassessment using validated instruments lets you monitor healing trajectories, catch early signs of deterioration, and make timely decisions about escalating interventions or referring to specialist wound care services. In this module, we'll examine the primary assessment frameworks and classification systems used to evaluate diabetic foot ulcers, pressure injuries, and venous leg ulcers with attention to vascular screening, risk stratification, and the full assessment process across clinical settings. Let's start with diabetic foot ulcer classification and risk stratification. Classifying diabetic foot ulcers relies on several validated systems, each designed to capture distinct dimensions of wound severity and prognostic risk. The International Working Group on the Diabetic Foot, or IWGDF 2023 update, recommends the SINBAD system, which stands for site, ischemia, neuropathy, bacterial infection, area, and depth, as the primary classification tool for communication among healthcare professionals. The wound, ischemia, and foot infection system, known as Wi-Fi, is recommended as an alternative when institutional resources and clinical expertise support its use. SINBAD provides a straightforward scoring mechanism that integrates anatomical and pathophysiological parameters relevant to healing prognosis, making it accessible across diverse practice settings. The Wi-Fi classification system offers a more granular assessment framework, integrating 3 critical domains: wound severity, ischemia grade, and foot infection status. Here's where it gets clinically useful. Wi-Fi scores of 1, 2, 3, and 4 are associated with one-year major amputation rates of approximately 0%, 8%, 11%, and 38% respectively, giving clinicians a quantitative basis for risk communication and treatment intensity decisions. The Wi-Fi system has been independently validated across multiple cohorts, confirming its capacity to predict wound healing outcomes in diabetic foot ulcer populations. The IDSA IWGDF classification further standardizes the language for bacterial infection stratification, providing a common framework for grading infection severity from uninfected through mild, moderate, and severe categories. Several additional assessment tools complement these primary classification systems. The DIMIS tool, which stands for Deep Maceration, Infection, Size, and Tunneling, has demonstrated reliability, validity, and responsiveness in predicting diabetic foot ulcer healing outcomes, making it a useful adjunct for thorough wound evaluation. The American Diabetes Association 2026 Standards of Care identify specific high-risk characteristics that increase the probability of ulcer development and recurrence, including history of prior ulceration, amputation, Charcot foot, peripheral artery disease, retinopathy, and renal disease. And here's where it gets interesting from a risk perspective. Risk factors independently associated with ulcer recurrence include elevated vibration perception threshold, exceeding 25 volts, with an odds ratio greater than 8, pre-ulcerative lesions, peripheral artery disease, and plantar foot location, each carrying odds ratios exceeding 8. Those are strong numbers. Recognizing these risk factors during your initial assessment enables targeted preventive interventions and appropriate surveillance scheduling. Now let's shift to pressure injury staging and assessment tools. Risk assessment for pressure injuries relies on multiple validated instruments, each with distinct advantages and recognized limitations. The Braden scale and Norton scale are the most commonly used screening tools, though the evidence shows that their sensitivity and specificity are limited, and clinical judgment remains an essential complement to standardized scoring. The American College of Physicians found that several risk assessment tools, including the Waterlow and Ramstadius scales, were equivalent to clinical judgment alone for reducing pressure ulcer incidence. That said, moderate quality evidence supports the ability of the Braden, Cubbon, and Jackson, Norton, and Waterlow scales to predict which patients are more likely to develop pressure ulcers, providing a structured framework for systematic screening. The pressure ulcer scale for healing, known as PUSH version 3.0, serves a different purpose from risk prediction tools. It offers a validated measure for monitoring healing progress in existing pressure injuries. PUSH 3.0 evaluates 3 parameters: wound size, exudate amount, and tissue type, generating a composite score that quantifies wound status and enables serial tracking of healing trajectory. Construct validity and responsiveness are supported by moderate to high-quality evidence, making PUSH 3.0 a reliable tool for clinical documentation and outcome measurement. If you're seeing deteriorating PUSH scores despite appropriate interventions, that should trigger your thinking about inadequate pressure offloading, unrecognized infection, or the need for advanced therapies. The National Pressure Injury Advisory Panel, or NPI-APP, staging system categorizes pressure injuries from Stage 1 non-blanchable erythema of intact skin through Stage 4 full-thickness tissue loss with exposed bone, tendon, or muscle, with additional categories for unstageable injuries and deep tissue pressure injuries. Accurate staging requires clinical skill in tissue assessment and recognition of anatomical landmarks, and it's essential for appropriate treatment selection and outcome benchmarking across healthcare settings. Vascular assessment is a critical and non-negotiable part of lower extremity wound evaluation. The ankle brachial index, or ABI, remains the most practical and widely available bedside vascular assessment tool, providing essential information on arterial sufficiency that directly informs compression therapy decisions and healing prognosis. An ABI greater than 0.8 or 0.9 is generally considered safe for starting full compression therapy in patients with venous leg ulcers. For patients with mild to moderate arterial disease, defined by an ABI between 0.5 and 0.8, compression may be modified by reducing the number of layers or transitioning to inelastic wraps with weekly monitoring to ensure adequate arterial perfusion. When the ABI falls below 0.5, compression therapy is contraindicated because of the risk of further compromising arterial flow, and vascular referral for revascularization assessment is warranted. Prognostic factors for venous leg ulcer healing extend well beyond vascular status. A 12-week longitudinal study of 754 patients identified independent predictors of slower healing, including wound area greater than 8.25 square centimeters, location other than the medial ankle, underlying disease duration exceeding 20 years, presence of multiple comorbidities, wound depth, presence of unpleasant odor, and presence of alert pathogens. Independent predictors of failure to heal within 24 weeks include larger wound area, longer wound duration, history of venous ligation or stripping, ABI less than 0.8, which is the strongest single predictor, with an adjusted odds ratio of 9.25, and greater than 50% fibrin coverage of the wound surface. These prognostic indicators let you identify patients at high risk for treatment failure early on, so you can get them to specialist wound care services sooner rather than later. Supplementary vascular assessment methods complement the ABI in more complex clinical scenarios. Transcutaneous oxygen pressure measurements, known as TSPO2, provide additional perfusion data, with values below 25 millimeters of mercury, indicating that healing is unlikely even with adjunctive therapies such as hyperbaric oxygen. Toe pressure measurements are particularly valuable in diabetic populations, where calcification of tibial arteries may falsely elevate ABI values. Semmes-Weinstein monofilament testing at 10 grams of pressure identifies loss of protective sensation in the foot, a critical risk factor for diabetic foot ulcer development that informs both prevention strategies and footwear recommendations. Doppler ultrasound assessment of pedal pulses distinguishes between biphasic, monophasic, and absent flow patterns, providing a rapid qualitative assessment of arterial perfusion status. Identifying high-risk populations is a prerequisite for implementing targeted prevention and surveillance strategies across all wound types. For diabetic foot ulcers, the ABCDFGI systematic approach to wound assessment and management provides a structured mnemonic framework that ensures you don't miss critical assessment domains during initial and serial evaluations. This systematic approach complements the Wi-Fi and SINBAD classification systems by giving you a practical bedside tool that organizes the assessment process into sequential, clinically meaningful steps applicable across practice settings. Pressure injury risk assessment in hospitalized populations reveals that certain patient groups carry disproportionately high vulnerability. In critically ill patients, an updated systematic review identified the most consistently significant independent risk factors as older age, limited mobility or activity, impaired perfusion, vasopressor use, and longer intensive care unit length of stay. Now, this is important. The existence of pressure injuries or scars from previous injuries on admission carries the highest independent risk, with an odds ratio of 51.9. For those who want a refresher, the odds ratio tells us how much more likely an outcome is in one group compared to another. So 51.9 means patients with prior pressure injuries are roughly 52 times more likely to develop new ones. That's followed by use of medical devices with an odds ratio of 3.2, surgery during hospitalization with an odds ratio of 2.2, and presence of forced posture with an odds ratio of 2.0. Among older adults aged 75 years and above in acute care settings, factors significantly associated with pressure injuries include low body mass index, low albumin level with an odds ratio of 0.51, cardiovascular disease with an odds ratio of 2.10, infection with an odds ratio of 1.91, bedridden status with an odds ratio of 1.85, and fecal or urinary incontinence with an odds ratio of 2.44. Non-blanchable erythema reliably predicts progression to stage 2 pressure injury, which drives home the importance of early skin assessment and preventive intervention as soon as you identify this clinical sign. Venous leg ulcer risk profiles are characterized by identifiable demographic and clinical features. Risk factors for venous leg ulcer development include age 55 years or older, family history of chronic venous insufficiency, higher body mass index, history of pulmonary embolism or superficial or deep venous thrombosis, lower extremity skeletal or joint disease, higher number of pregnancies, parental history of ankle ulcers, and physical inactivity. Poor prognostic signs for venous leg ulcer healing include ulcer duration longer than 3 months, initial ulcer length of 10 centimeters or more, presence of lower limb arterial disease, advanced age, and elevated body mass index. Recognizing these high-risk profiles lets you implement intensified surveillance, earlier specialist referral, and proactive management strategies designed to prevent wound development and optimize healing when wounds do occur. The TIME framework, which stands for Tissue, Infection and Inflammation, Moisture and Edge, provides a universally applicable systematic approach to wound bed preparation and ongoing assessment across all wound types and clinical settings. Tissue assessment involves identifying and quantifying devitalized tissue, guiding decisions about debridement method and frequency. Infection and inflammation management addresses bacterial bioburden through clinical assessment, microbiological culture when indicated, and appropriate antimicrobial therapy. Moisture balance requires matching dressing selection to exudate volume, with the goal of maintaining optimal wound hydration, neither too dry for cellular migration nor too wet for peri-wound skin integrity. Edge assessment evaluates wound margin characteristics, including signs of epithelial advancement, undermining, or rolled edges that may indicate chronicity or malignancy. The systematic wound assessment process extends beyond the TIME framework to include patient history, full physical examination, wound measurement and documentation, and identification of underlying etiologies. How you implement validated assessment tools varies by care setting. In inpatient settings, thorough assessments should happen immediately upon admission and at regular intervals for high-risk patients. In outpatient and home care settings, accurate diagnosis, thorough documentation, and identification of contributing etiologies take priority, with referral to specialist wound clinics recommended for complex wounds or those not responding to standard therapy within 4 to 6 weeks. The quality of your initial and serial assessment directly impacts treatment decisions, resource allocation, and patient outcomes. Tools that predict poor healing outcomes such as Wi-Fi, scores of 2 or higher, low ABI values, or lack of measurable progress at 4 weeks identify candidates for early advanced therapy referral and prevent unnecessary delays in escalating care. Moving on to Module 2, Evidence-Based Wound Management by Etiology. Effective wound management requires interventions tailored to the specific pathophysiology of each wound type. Shared principles like debridement, moisture balance, infection control, and patient optimization underpin the management of all chronic wounds, but the relative emphasis and specific therapeutic strategies differ substantially across diabetic foot ulcers, pressure injuries, venous leg ulcers, and surgical site infections. This module examines the current evidence base for management of each major wound etiology, drawing on data from systematic reviews, meta-analyses, and clinical practice guidelines to give you a thorough framework for clinical decision-making. Let's start with diabetic foot ulcer management. Standard care for diabetic foot ulcers rests on 5 essential and interrelated principles: debridement, infection control, moisture balance, offloading, and vascular assessment. These foundational interventions are universally recommended as first-line management, with advanced therapies reserved for wounds that don't show adequate healing response after 4 weeks of standard care. Debridement is central to wound bed preparation and ongoing wound management. Weekly sharp debridement is associated with significantly higher healing rates compared with less frequent debridement, 55% versus 28%. That's a big deal, and it really drives home the importance of establishing consistent debridement schedules. The mechanism of benefit involves removal of devitalized tissue, reduction of bacterial bioburden, disruption of biofilm, and stimulation of the acute wound healing response through release of growth factors and cytokines. Methods include sharp debridement by skilled clinicians, enzymatic debridement using agents such as collagenase, and autolytic debridement supported by appropriate moisture management. Offloading is the single most important intervention for plantar diabetic foot ulcers. Knee-high non-removable devices, including total contact casts and knee-high walkers rendered irremovable, reduce plantar pressure by 80 to 90% compared with standard footwear. Network meta-analysis consistently rank non-removable offloading devices among the most effective interventions for both early and late-stage healing, though they carry a moderate risk of adverse events, primarily falls. Why the emphasis on non-removable devices? Because patient adherence with removable offloading is typically insufficient to achieve therapeutic pressure reduction. Making the device irremovable is a critical determinant of clinical effectiveness. Infection control demands prompt identification and classification using the IDSA-IWGDF system. Systemic antibiotics are indicated for clinically infected wounds, and glycemic control with blood glucose targets below 200 mg per deciliter is essential for optimizing host defense mechanisms. Diagnosing osteomyelitis, a particularly challenging complication, gets easier with specific laboratory findings. An erythrocyte sedimentation rate greater than 70 mm per hour substantially improves diagnostic accuracy, with a likelihood ratio of 11, and the combination of a positive probe-to-bone test with plain film radiography can be sufficient for diagnosis in hospitalized patients, with a likelihood ratio of 14. Vascular assessment is integral to prognosis and treatment planning. The presence of peripheral artery disease substantially increases the risk of failure to heal and major lower limb amputation. Delayed revascularization is associated with demonstrably slower healing and higher amputation rates. A prospective study of 478 patients showed improved wound healing among those receiving vascular referral within 56 days, compared with longer delays to revascularization, with a hazard ratio of 1.96. A retrospective analysis of 314 patients with diabetes reported that waiting more than 14 days before lower extremity revascularization was associated with a higher rate of major amputation compared with earlier intervention, with an odds ratio of 3.1. The takeaway here is clear. Expedited vascular consultation in patients presenting with ischemic diabetic foot ulcers can make the difference between limb salvage and amputation. Advanced therapies should be considered for chronic diabetic foot ulcers that aren't responding to standard care, defined as less than 50% reduction in wound size after 4 weeks of appropriate management. Negative pressure wound therapy, or NPWT, is particularly effective for deep and postoperative wounds. A meta-analysis of 943 patients from 9 randomized clinical trials reported that NPWT was associated with improved healing compared with moist wound healing, with an odds ratio of 3.6. Placenta-derived products have shown substantial benefit in healing non-infected, non-ischemic diabetic foot ulcers. A meta-analysis of 11 multi-center randomized clinical trials involving 655 participants demonstrated higher complete resolution at 12 to 16 weeks with placenta-derived products compared with standard care, 66.9% versus 34.1%. Sucrose octasulfate dressings are particularly effective for neuroischemic ulcers, with the Explorer study demonstrating healing at 20 weeks in 48% of patients receiving active therapy versus 30% with standard care, an adjusted odds ratio of 2.60. Topical oxygen therapy offers particular promise for home care settings, with pooled results from meta-analysis showing improved healing compared with sham controls, 43% versus 28%. Medication considerations are increasingly recognized as important modulators of diabetic foot ulcer outcomes. Semaglutide, a GLP-1 receptor agonist, has demonstrated benefits independent of baseline diabetes duration, hemoglobin A1C levels, body mass index, or concomitant SGLT2 inhibitor treatment. In contrast, canagliflozin, an SGLT2 inhibitor, was associated with an increased risk of lower limb amputation, predominantly affecting toes, in the CANVAS trial, and discontinuation should be considered if an individual develops a significant lower limb complication. Now let's talk about pressure injury prevention and management. Pressure injury prevention works best when you implement bundled interventions that address multiple risk factors at once, rather than relying on single intervention approaches in isolation. A modified Delphi study achieving international consensus identified a minimum intervention set stratified by risk level for critically ill patients. All patients should receive risk assessment within 2 hours of admission, 8 hourly risk reassessment, and use of disposable incontinence pads. Moderate and high-risk patients should additionally receive a reactive mattress support surface, a heel offloading device, and repositioning at least every 2 hours. High-risk patients should further receive nutritional supplements, preventative dressings at the sacrum, heels and trochanters, an active mattress support surface, and a pressure redistributing cushion for sitting. Support surface selection is a critical determinant of prevention effectiveness. The American College of Physicians recommends that clinicians choose advanced static mattresses or advanced static overlays for patients at increased risk, based on a strong recommendation supported by moderate quality evidence. Advanced static mattresses and overlays are associated with a lower risk for pressure ulcers compared with standard hospital mattresses, though no specific brand has shown superiority. The 2019 International Pressure Injury Guidelines recommend high-specification foam mattresses and medical-grade sheepskin surfaces as more beneficial alternatives to regular foam mattresses. Dynamic surfaces, including alternating pressure mattresses, can offload high-pressure areas without caregiver engagement, though current evidence doesn't demonstrate clear superiority over static systems for pressure ulcer prevention. A systematic review of 14 studies examining nursing interventions for pressure injury prevention in critically ill patients found that the most effective approaches included pressure injury, prevention bundles, repositioning combined with surface support, prevention of medical device-related pressure injuries, and access to clinical expertise. In long-term care facilities, where pressure ulcers occur in up to 20% of residents, successful prevention programs incorporate simplification and standardization of pressure, ulcer-specific interventions, multidisciplinary team involvement, designated skin champions, ongoing staff education, and sustained audit and feedback mechanisms. Here's a number that should stop you in your tracks. Infected pressure ulcers with secondary bacteremia carry a 50% mortality rate. Local wound care for established pressure injuries follows the time framework principles, with debridement indicated for necrotic tissue removal and dressing selection guided by wound bed characteristics and exudate volume. Local wound care is generally sufficient for stages 1 and 2 pressure injuries, while stages 3 and 4 may require surgical intervention including flap coverage or tissue transfer. The Wound Healing Society 2023 Guidelines for Pressure Ulcer Treatment provide detailed evidence-based recommendations for management across all stages, emphasizing the importance of addressing both local wound factors and systemic contributors, including nutritional status, moisture management, and pressure redistribution. These guidelines integrate the most current evidence from systematic reviews and clinical trials to establish standardized management protocols applicable across acute care, long-term care, and home health settings. Electrical stimulation has emerged as the most extensively studied physical therapy adjunct for pressure injury management. A Cochrane review found that electrical stimulation probably increases the proportion of pressure ulcers healed, with a relative risk of 1.99 and moderate certainty evidence, supporting its inclusion in management protocols for stages 2 through 4 pressure injuries. The mechanism of benefit involves enhancement of cellular migration, proliferation, and collagen synthesis through application of direct or pulsed electrical current to the wound bed and periwound tissue. Now let's look at venous leg ulcer management. Compression therapy is the cornerstone of venous leg ulcer management, supported by strong recommendation and high-quality evidence. A Cochrane systematic review of 14 studies involving 1,391 participants showed that compression therapy probably shortens time to complete healing, with a pooled hazard ratio of 2.17, and increases the proportion of ulcers healed within 12 months, with a risk ratio of 1.77, representing moderate certainty evidence. Compression therapy also probably reduces mean pain scores, with a pooled mean difference of -1.39. Multi-component compression systems containing elastic bandages are substantially more effective than inelastic systems alone, and compression should be applied from toes to knees with graded pressure of 30 to 40 millimeters of mercury at the ankle when the ankle brachial index exceeds 0.8. Early endovenous ablation of superficial venous incompetence combined with compression improves venous leg ulcer healing compared with compression alone, and this is supported by high-certainty evidence. The pooled hazard ratio for time to complete ulcer healing with combined endovenous ablation and compression versus compression alone is 1.41 and an I-squared of 0%. I-squared is a measure of how much the results varied across studies, and 0% means there was essentially no variability, so these findings are remarkably consistent. Moderate certainty evidence suggests that the proportion of ulcers healed at 90 days is probably higher with the combined approach. Early endovenous ablation is also probably cost-effective at 1 year, with a 99% probability at £20,000 per quality-adjusted life year. Adjunctive pharmacotherapy enhances compression-based management. Pentoxifylline 400 mg 3 times daily as an adjunct to compression was more effective than placebo for complete healing or significant improvement, with a risk ratio of 1.70 versus placebo alone, and a risk ratio of 1.56 versus placebo plus compression in a meta-analysis of 11 trials. Limited evidence from 2 small randomized controlled trials suggests potential benefit from aspirin 300 mg daily as an adjunct to compression. So what's actually driving venous leg ulcer chronicity? It's a cascade of events triggered by sustained venous hypertension. Ambulatory venous pressure exceeding 80 mm of mercury leads to capillary endothelial damage, pericapillary fibrin cuff deposition, white blood cell trapping, and release of proteolytic enzymes and inflammatory mediators that damage surrounding tissue. This understanding informs the rationale for compression therapy as the primary intervention. By reducing ambulatory venous pressure, compression interrupts the cascade at its origin. But here's the catch. Recurrence rates reach 70% without sustained compression, which really shows the chronic, relapsing nature of the underlying disease and the need for lifelong compression in patients with established venous insufficiency. For venous leg ulcers that aren't improving after 4 to 6 weeks of optimal compression therapy, typically defined as less than 30% reduction in wound size within 4 weeks, advanced therapies should be considered. Split-thickness skin grafting demonstrates greater success rates in chronic venous leg ulcers compared with other chronic leg ulcer types, with wound bed perfusion identified as the primary determinant of graft viability. The IWGDF 2023 Guidelines on Interventions to Enhance Healing emphasize that for diabetic foot ulcers failing standard care, the decision to employ advanced therapies should be guided by wound characteristics, patient comorbidities, and resource availability, with evidence supporting a stepped approach from standard care through advanced dressings to cellular therapies and surgical intervention. Referral to a wound specialist is indicated when standard management fails to produce measurable healing progress within the expected timeframe. The causes, prevention, and management of diabetes-related foot ulcers require coordinated multidisciplinary approaches that address both local and systemic factors contributing to wound chronicity. Let's now talk about surgical site infection prevention. Surgical site infections are a preventable complication that significantly increases morbidity, length of stay, and healthcare costs. A thorough evidence-based approach to surgical site infection prevention integrates perioperative risk modification with intraoperative and postoperative strategies. Patient risk factors include perioperative hyperglycemia with serum glucose at or exceeding 180 to 200 mg per deciliter, smoking, obesity with a body mass index of 30 or higher, poor nutritional status, subcutaneous tissue depth exceeding 3 cm, coexistent infection at a remote body site, immunodeficiency, and methicillin-resistant Staphylococcus aureus colonization. The American Diabetes Association 2026 Standards of Care for Diabetes Management in Hospital Settings provide specific guidance on perioperative glycemic targets that directly impact surgical site infection risk, recommending blood glucose maintenance below 180 to 200 mg per deciliter throughout the perioperative period, with insulin infusion protocols preferred for major surgical procedures. This recommendation is supported by evidence that perioperative hyperglycemia is independently associated with increased surgical site infection risk across multiple surgical specialties. The World Health Organization recommendations for surgical site infection prevention emphasize 6 core evidence-based strategies: appropriate antibiotic prophylaxis timed to ensure therapeutic tissue levels at the time of incision, perioperative glycemic control to maintain blood glucose below 200 mg per deciliter, maintenance of perioperative normothermia, optimization of tissue oxygenation through appropriate fluid management and supplemental oxygen, chlorhexidine alcohol skin preparation at the surgical site, and meticulous surgical technique with attention to tissue handling, hemostasis, and dead space elimination. In colorectal surgery, high-quality evidence confirms surgical site infection correlation with obesity, American Society of Anesthesiologists score of 3 or higher, and emergent surgery. Moderate quality evidence demonstrates additional associations with male sex, diabetes, mellitus, inflammatory bowel disease, surgery duration exceeding 180 minutes, and stoma formation. Prophylactic negative pressure wound therapy has emerged as a promising intervention for high-risk surgical wounds. A randomized clinical trial evaluating prophylactic NPWT for vascular groin incisions demonstrated reduced wound complications compared with standard dressings. Integration of enhanced recovery after surgery, or ERAS, protocols with wound-specific interventions optimizes the perioperative environment for healing. ERAS protocols encompass preoperative optimization including nutritional assessment and prehabilitation, intraoperative strategies including minimally invasive techniques and normothermia maintenance, and postoperative early mobilization supported by physical therapy. The perioperative management of obese patients warrants particular attention, as obesity demonstrates a dose-dependent relationship with surgical site infection risk. Following mastectomy, infection rates increase from 4.66% at a BMI of 20 to 25, to 7.06% at a BMI of 30 to 40, to 10.58% at a BMI above 40. Moving on to Module 3. Dressing selection, nutritional interventions, and interventions with limited efficacy. The principle of moist wound healing, first established in landmark research showing that occlusive environments accelerate epithelialization, remains the foundational model guiding modern dressing selection. Moist wound environments prevent cellular dehydration, help keratinocytes migrate across the wound bed, promote collagen synthesis and angiogenesis, and reduce pain at dressing changes. The goal of dressing selection isn't to find one universally superior product. It's to match dressing characteristics to the specific wound environment, balancing absorptive capacity with moisture donation based on exudate volume, wound depth, tissue type, peri-wound skin condition, and patient-specific factors including ease of application and comfort. Modern wound dressings fall into several functional categories, each suited to distinct clinical scenarios. Films provide a semi-permeable barrier appropriate for superficial wounds with minimal exudate and for secondary dressing applications. Foam dressings offer moderate to high absorptive capacity and are widely used for exudative wounds, though a Cochrane review found that foam dressings don't promote healing of diabetic foot ulcers beyond what basic wound contact dressings achieve. Alginates and hydrofibers derived from seaweed-based calcium alginate or carboxymethyl cellulose fibers provide high absorptive capacity while maintaining moisture balance at the wound dressing interface, making them particularly appropriate for heavily exudating wounds. Hydrogels are the preferred choice for minimally exudative or dry wounds, creating and maintaining the moisture necessary for autolytic debridement and epithelialization. Hydrocolloid dressings form a gel on contact with wound exudate, providing moderate absorption and an occlusive environment, though they may macerate peri-wound skin if exudate exceeds their absorptive capacity. A thorough Cochrane systematic review of dressings and topical agents for treating venous leg ulcers evaluated multiple dressing types within a network meta-analysis framework, providing the most rigorous comparative effectiveness data available for dressing selection in this population. The review found that the certainty of evidence comparing different dressing types was generally low, with most comparisons limited by small sample sizes, methodological heterogeneity, and risk of bias. So what does that mean for you in practice? It supports a pragmatic approach to dressing selection based on clinical assessment of wound characteristics, patient preferences, and cost considerations rather than adherence to a single best dressing type. The review reinforced the principle that the most important factor in venous leg ulcer management is adequate compression therapy, with dressing selection serving as an adjunct to, not a substitute for, appropriate compression. Silver-containing dressings occupy a specific but contested niche in wound management. A network meta-analysis of dressings for venous leg ulcers found some evidence that silver dressings may increase the probability of healing compared with non-adherent dressings and moderate certainty evidence, though the overall network evidence was of low certainty. Current evidence supports short-term use of silver dressings in wounds with clinical signs of critical colonization or localized infection, but routine prophylactic use in non-infected wounds isn't supported by the evidence base. Hyaluronic acid-containing dressings and topical agents for chronic wound healing have been evaluated in a Cochrane systematic review, which found insufficient evidence to determine their effectiveness compared with standard dressings. When it comes to dressings for ischemic wounds, particular caution is needed. A Cochrane systematic review found insufficient evidence to determine whether the choice of topical agent or dressing affects the healing of arterial leg ulcers, with only 2 small trials meeting inclusion criteria. The fundamental principle is that no dressing can overcome inadequate tissue perfusion. In chronic limb-threatening ischemia, local wound care before revascularization should be limited to dry, sterile dressings, with principles of moist wound healing applied only after adequate perfusion has been restored. Similarly, moist gauze dressings are associated with slower wound healing compared with modern dressings and are costly in professional time due to the frequency of dressing changes required. They can damage the wound bed upon removal and should only be used when other wound dressing types aren't available. Let's turn to nutritional assessment and optimization in wound care. Nutritional status is a critical but frequently under-assessed determinant of wound healing outcomes across all wound types. Malnutrition is an independent risk factor for non-healing wounds, with the Subjective Global Assessment, or SGA, demonstrating superior predictive performance with an area under the curve, or AUC, of 0.70. The AUC is essentially a prediction accuracy score that runs from 0.5, no better than a coin flip, up to 1.0, a perfect prediction. So 0.70 indicates moderate predictive ability. That compares with the Global Leadership Initiative on Malnutrition, or GLIM, criteria with an AUC of 0.63 for predicting non-healing diabetic foot ulcers. Malnutrition was identified as an independent risk factor for non-healing in this population, with a relative risk of 1.84. The Malnutrition Universal Screening Tool, known as MUST, provides a validated, rapid screening method appropriate for community and outpatient settings, while the Mini Nutritional Assessment, or MNA, offers particular utility in geriatric populations at risk for pressure injuries. Protein supplementation forms the cornerstone of nutritional intervention for wound healing. Optimal daily protein intake for patients with chronic wounds ranges from 1.25 to 1.5 grams per kilogram of body weight, with higher intakes recommended for patients with pressure injuries and those with significant exudate losses. A systematic review of oral nutritional supplement composition and chronic wound healing found that protein-enriched formulas with specific amino acid profiles, particularly those containing arginine, glutamine, and hydroxymethylbutyrate, or HMB, demonstrated improved healing outcomes in select populations. A post-hoc analysis revealed that patients with low albumin of 40 grams per liter or below, or poor limb perfusion with an ABI below 1.0, were 1.70 and 1.66 times more likely to heal with arginine, glutamine, and HMB supplementation, respectively. That suggests nutritional interventions may be most beneficial in patients with identifiable deficiency states. Pressure ulcer-specific nutritional considerations go beyond general wound healing requirements. The relationship between pressure ulcers and nutrients has been explored through systematic review evidence, showing that nutritional deficiencies are both a risk factor for pressure injury development and a barrier to healing of established injuries. Weight loss can increase the risk of pressure injuries, which really highlights the importance of caloric adequacy alongside protein and micronutrient optimization in vulnerable populations, including elderly patients in long-term care settings. Nutritional screening should be performed on admission and at regular intervals using validated tools such as the Malnutrition Universal Screening Tool or Mini Nutritional Assessment, with referral to a registered dietitian for patients identified as malnourished or at nutritional risk. Micronutrient assessment and targeted correction are equally important. Vitamin C is essential for collagen synthesis and immune function. Zinc plays critical roles in cell proliferation, immune defense, and wound contraction. An iron deficiency impairs oxygen delivery to healing tissues through its effect on hemoglobin synthesis. For patients identified with specific micronutrient deficiencies through laboratory assessment, targeted supplementation improves healing outcomes, though routine supplementation, in the absence of documented deficiency, hasn't demonstrated consistent benefit. Pressure ulcer-specific nutritional guidelines emphasize that weight loss can increase the risk of pressure injuries, reinforcing the importance of caloric adequacy alongside protein and micronutrient optimization. However, the evidence base for nutritional interventions in wound care has important limitations that we need to be honest about. A Cochrane review of nutritional interventions for diabetic foot ulcers found very low certainty evidence, with no clear benefit demonstrated for protein-enriched formulas, arginine, glutamine, HMB combinations, zinc, magnesium, omega-3 fatty acids, or vitamin D when assessed across the general diabetic foot ulcer population. This finding highlights a key distinction between population-level evidence and individualized clinical benefit. Nutritional assessment and targeted intervention for patients with documented deficiencies remains supported by the evidence, even as universal supplementation strategies lack strong support. Let's now look at interventions with reduced effectiveness in complex patients. Several wound care interventions that work well in uncomplicated wounds show substantially reduced effectiveness in patients with comorbidities, including peripheral artery disease, obesity, and other systemic conditions. Understanding these evidence gaps matters for appropriate resource allocation and to prevent implementing costly or potentially harmful treatments that don't address underlying physiological barriers to healing. Hyperbaric oxygen therapy, or HBOT, shows inconsistent results in patients with peripheral artery disease, particularly when revascularization isn't performed. The 2024 American College of Cardiology and American Heart Association Guidelines for Management of Lower Extremity Peripheral Artery Disease note that one small randomized controlled trial in patients with foot ulcers and PAD showed a significant decrease in ulcer area at 6 weeks, but no significant differences at 6 months in ulcer size, complete healing, or amputation rates. A systematic review and meta-analysis of HBOT for diabetic foot ulcers with arterial insufficiency reported reduction in major amputation, 10.7% versus 26.0%, with a number needed to treat of 7 but no difference in wound healing or minor amputations. Transcutaneous oxygen pressure less than 25 millimeters of mercury indicates that healing is unlikely even with hyperbaric oxygen therapy. HBOT may be considered as an adjunctive therapy to revascularization, but should not substitute for restoration of adequate arterial perfusion. Prophylactic negative pressure wound therapy shows mixed results in obese surgical patients. A multicenter randomized controlled trial of 1,620 obese women undergoing cesarean delivery found no significant difference in surgical site infection rates with prophylactic NPWT compared with standard wound dressing, 4.9% versus 5.6%, with significantly higher adverse skin reactions in the NPWT group. However, in vascular surgery, patients at high risk for wound complications, specifically those with body mass index exceeding 30 PANAS, reoperation, or prosthetic grafts, NPWT significantly reduced major wound complications from 25% to 8.5%. These divergent findings tell us that the benefit of prophylactic NPWT is population-specific and can't be generalized across all obese surgical patients. Compression therapy effectiveness is substantially modified in patients with concomitant arterial disease. For patients with mild to moderate arterial disease, with an ABI between 0.5 and 0.8, compression must be modified by using inelastic wraps or reducing the number of layers, with weekly monitoring to ensure adequate arterial flow. In patients with severe arterial disease with an ABI below 0.5, compression therapy is contraindicated because of the risk of further reducing arterial flow. Reduced compression of 20 to 30 millimeters of mercury is successful and safe for venous leg ulcer healing when the ABI falls between 0.9 and 0.6, though caution is advised when the ABI is less than 0.6 because this indicates an arterial anomaly requiring revascularization. Skin grafting procedures also show reduced success in patients with vascular disease. While skin grafts achieve greater success rates in chronic venous leg ulcers compared with other chronic ulcer types, wound bed perfusion is the primary determinant of graft viability, with each unit increase in perfusion associated with a 40 to 48 percentage point decrease in necrosis extension. Now we're moving into Module 4, Impact of Comorbidities on Wound Healing. Comorbid conditions profoundly alter wound healing physiology through multiple interconnected mechanisms, substantially reducing healing rates and increasing complications across all wound types. The effect of comorbidities extends beyond individual disease processes to include the cumulative and synergistic interactions between multiple concurrent conditions. Patients with chronic wounds frequently present with 3 or more comorbidities, creating complex clinical scenarios where standard management algorithms designed for single etiology wounds may prove insufficient. The typical wound care patient carries multiple comorbidities that interact synergistically to impair the coordinated biological processes required for tissue repair. Prognostic factors for delayed healing that coincide across various wound etiologies and settings include male gender, renal disease, diabetes, peripheral arterial disease, decline in activities of daily life, wound duration, wound area, wound location, high-stage Wi-Fi classification, gangrene, infection, previous ulcers, and low ankle brachial index. Understanding the specific mechanisms by which each major comorbidity impairs healing lets you implement targeted interventions and modify treatment algorithms for complex patients. Let's start with obesity and its impact on wound healing. Obesity impairs wound healing through multiple interconnected mechanisms operating at systemic, cellular, and tissue levels. Systemically, obesity causes chronic inflammation, oxidative stress, mitochondrial dysfunction, and apoptosis, all factors linked to slow and incomplete epithelial regeneration. In the integumentary system, obesity causes expansion of the skin surface area and changes in collagen deposition, with inflammatory immune alterations, altered collagen formation through fibroblast senescence, and excessive degradation of extracellular matrix proteins, contributing to sustained inflammation and decreased mechanical resistance of the skin. At the vascular level, obesity impairs wound closure through a vasculogenic mechanism involving reduced endothelial progenitor cell function, with progenitor cells from obese individuals demonstrating impaired adhesion, migration, and proliferation compared with those from non-obese subjects. Adipose tissue in obese individuals functions as an active endocrine organ, secreting pro-inflammatory cytokines including tumor necrosis, factor alpha, interleukin-6, and leptin that maintain a state of chronic low-grade systemic inflammation. This inflammatory environment disrupts the precisely coordinated transition from the inflammatory phase to the proliferative phase of wound healing, resulting in prolonged inflammation and delayed tissue repair. On top of that, the relative hypovascularity of adipose tissue creates localized hypoxia at the wound site, further impairing fibroblast function and collagen deposition. The impact of obesity on surgical site infection risk follows a dose-dependent relationship. A 7-year analysis of over 5.5 million patients across 9 surgical specialties confirmed that compared with normal weight patients, overweight and obese patients in classes 1, 2, and 3, all had higher adjusted odds of developing infection, venous thromboembolism, and renal complications. In colorectal surgery, the incremental risk is particularly pronounced, with Class 3 obesity, defined as a BMI of 40 or higher, associated with an adjusted odds ratio of 2.1 for surgical site infection. Obesity also significantly impacts venous leg ulcer healing, with 84% of patients in one large cohort study being obese and increased body mass index associated with delayed wound healing. The challenges that obesity presents for compression therapy adherence are clinically significant. Although compression above 30 millimeters of mercury is recommended for ulcer healing, those levels cause discomfort that reduces compliance, often forcing clinicians to use lower compression levels of 20 to 30 millimeters of mercury, with potentially reduced efficacy. Now let's look at peripheral artery disease and its effect on wound healing. Peripheral artery disease represents one of the most significant prognostic factors for delayed wound healing across multiple wound etiologies. In patients with diabetes, PAD ranges from atherosclerotic disease of the iliac and femoropopliteal arterial segments to more distal disease affecting the tibial and peroneal arteries. Extensive involvement of limb arteries, particularly those below the knee, increases the risk of chronic limb-threatening ischemia and the need for revascularization. Arterial medial calcification, common in diabetic populations, is linked to higher risks of foot ulcers and amputation, while microvascular disease affecting arterioles of the foot and toes contributes to poor wound healing through combined effects with neuropathy. Here's a number that puts this in perspective. In patients with diabetes, PAD, and a diabetic foot ulcer who aren't revascularized, the limb salvage rate is approximately 50% at 1 year. Among persons with PAD, those with diabetes experience greater walking impairment, higher mortality, a higher prevalence of amputation, and a higher prevalence of atherosclerosis below the knee than those without diabetes. The incidence of major adverse limb events, meaning severe ischemia resulting in revascularization or amputation, ranges from 12.9% to 15.2% over 1.8 to 2.7 years of follow-up. The timing of revascularization is a critical determinant of outcomes. Delayed revascularization is associated with demonstrably slower healing and higher amputation rates, with a prospective study of 478 patients identifying improved wound healing among those receiving vascular referral within 56 days compared with longer delays. A retrospective analysis of 314 patients with diabetes found that waiting more than 14 days before lower extremity revascularization was associated with a significantly higher rate of major amputation compared with earlier intervention, with an odds ratio of 3.1. These data make a compelling case for getting patients to vascular consultation and intervention as quickly as possible when they present with ischemic wounds. PAD is also the strongest single predictor of failure to heal venous leg ulcers within 24 weeks, with an ABI less than 0.8 carrying an adjusted odds ratio of 9.25. Mixed arteriovenous disease accounts for approximately 20% of leg ulcers and requires careful vascular assessment before starting compression therapy. Let's turn now to diabetes mellitus and impaired wound healing. Diabetes impairs wound healing through a complex interplay of hyperglycemia-mediated cellular dysfunction, neuropathy, nephropathy, peripheral vascular disease, and impaired immune defense. The diabetic wound environment is characterized by persistent unresolved inflammation, decreased angiogenesis, biofilm involvement, non-migratory endothelialization, and defective white cell function that perpetuates ulceration and promotes secondary infection. At the molecular level, a high glucose environment enhances interleukin-8 production via the EGFR-ERK pathway in a reactive oxygen species-dependent manner, leading to increased neutrophil recruitment and intense inflammation associated with delayed healing. Persistent wound stress in type 2 diabetes creates a pathological cycle connecting local tissue injury with systemic organ involvement, affecting the cardiovascular system, kidneys, immune system, and nervous system. The diabetic internal environment, including hyperglycemia, insulin resistance, oxidative stress, vascular damage, and immune dysregulation, reshapes the wound microenvironment and disturbs the orderly sequence of hemostasis, inflammation, proliferation, and remodeling that characterizes normal wound healing. Both diabetes and hyperglycemia are considered independent major risk factors for small vessel disease, altering properties of skin and underlying tissue that predispose to injury while simultaneously limiting the capacity to heal. Medication considerations add further complexity to wound management in diabetic patients. Semaglutide, a GLP-1 receptor agonist, has demonstrated cardiovascular and metabolic benefits that may indirectly support wound healing. In contrast, canagliflozin, an SGLT2 inhibitor, was associated with an increased risk of lower limb amputation in the CANVAS trial, and discontinuation should be considered if an individual develops a significant lower limb complication, such as a diabetic foot ulcer, osteomyelitis, or gangrene. Now let's discuss chronic kidney disease, malnutrition, and immunosuppression. Chronic kidney disease substantially impairs wound healing through the accumulation of uremic toxins, vitamin deficiencies, compromised angiogenesis, and impaired hypoxia-inducible factor 1 alpha or HIF-1 alpha signaling. Patients with diabetes and chronic kidney disease on dialysis are categorized as high-risk Category 3 by the International Working Group on the Diabetic Foot, requiring quarterly foot screenings. The clinical significance of this combined risk is substantial. Chronic kidney disease significantly increases 10-year mortality for patients with diabetic foot ulcers compared with those with ulcers alone, both with and without amputation. Monthly foot examinations conducted by dialysis nurses resulted in a 17% reduction in major amputation rates, demonstrating the benefit of intensified monitoring in this vulnerable population. An interprofessional approach supported by podiatry is recommended for individuals with foot ulcers and high-risk feet, including those on dialysis. The combined impact of diabetes and chronic kidney disease on wound healing outcomes is particularly severe, with 10-year mortality significantly increased for patients carrying both diagnoses compared with either condition alone. The basis for this synergistic effect involves the superimposition of uremic vasculopathy, impaired immune function from both conditions, accelerated atherosclerosis, and disrupted calcium phosphate metabolism that further impairs tissue perfusion. Managing these patients demands close collaboration between wound care providers, nephrologists, and endocrinologists to optimize dialysis adequacy, glycemic control, and nutritional support simultaneously. Malnutrition and hypoproteinemia are independent risk factors for non-healing across all wound types. The subjective global assessment demonstrated superior performance compared with GLIM criteria for predicting non-healing diabetic foot ulcers, with malnutrition carrying a relative risk of 1.84 for non-healing. Prognostic factors for delayed healing in community settings include chronic kidney disease, obesity, non-adherence to treatment, and interference of the wound with daily routines. Immunosuppressive therapy affects wound healing to varying degrees depending on the specific agent and mechanism of action. Corticosteroids and mechanistic target of rapamycin, or mTOR inhibitors, most consistently demonstrate detrimental effects on wound healing, while evidence for other classes of immunosuppressants is limited with varying effects described. Patient risk factors for surgical site infection related to immunosuppression include chronic steroid use, chemotherapy, and MRSA colonization. Managing perioperative immunosuppression in patients undergoing surgical procedures requires careful coordination between wound care teams, surgeons, and rheumatologists or transplant physicians to balance infection risk against the consequences of medication withdrawal. Let's wrap up this module by discussing multidisciplinary management of complex patients. Optimal management of wounds in patients with multiple comorbidities demands coordinated multidisciplinary care that addresses both local wound factors and systemic disease optimization. The American Heart Association scientific statement emphasizes that management of diabetic foot ulcers is optimal when delivered by a multi-specialty care team addressing smoking cessation, glycemic control, cardiovascular risk factor modification, and nutrition. For patients with PAD and diabetic foot ulcers, early revascularization within 14 days significantly improves limb salvage rates, making expedited vascular referral essential. For venous leg ulcer patients with elevated BMI or concomitant arterial disease, modified compression protocols and early referral to wound specialists are indicated. Integrating comorbidity-specific assessment and targeted interventions into care plans that incorporate enhanced recovery after surgery protocols, glycemic control, nutritional optimization, and individualized wound care strategies optimizes healing outcomes and reduces complications across all wound types. Now we're moving into Module 5, AI Diagnostic Accuracy and Clinical Decision Support in Wound Care. Artificial intelligence systems have achieved remarkable diagnostic accuracy across multiple wound types and care settings, demonstrating performance that meets or exceeds expert clinician assessment in several validated applications. The evidence base now includes prospective clinical trials, systematic reviews, and real-world validation studies with performance metrics that are increasingly competitive with specialized clinician evaluation. As the wound care field faces growing patient volumes, workforce constraints, and the need for standardized documentation, AI-powered diagnostic tools offer a promising approach to wound assessment that can improve accuracy, efficiency, and accessibility of care. This module examines the diagnostic performance of AI tools across wound types, wound measurement and tissue classification capabilities, image quality optimization, explainable AI principles, and the integration of multimodal data for clinical decision support. Let's start with AI accuracy for diabetic foot ulcer detection and classification. AI-assisted wound assessment for diabetic foot ulcers has built the strongest evidence base among chronic wound types. In a multi-center proof-of-concept clinical evaluation involving 81 patients and 203-foot photographs, an AI system deployed on a low-end smartphone achieved a sensitivity of 91.6% and specificity of 88.6% for automated diabetic foot ulcer detection, with specificity improving to 92.4% after algorithmic refinement. Inter- and intra-rater reliability for clinician agreement with the AI system was excellent, with Krippendorf's alpha exceeding 0.80 for all comparisons, indicating that AI-generated assessments achieve consistency at or above the level of expert human agreement. The DFU_XI framework represents a significant step forward in both accuracy and interpretability of AI wound diagnosis. This framework incorporates explainability techniques including SHAP, which stands for Shapley Additive Explanations, LIME, which stands for Local Interpretable Model Agnostic Explanations, and Gradient-Weighted Class Activation Mapping, known as GradCAM, and it achieved 98.8% accuracy, 99.3% precision, 97.7% recall, an F1 score of 98.5%, and an AUC of 98.6%. The integration of explainability methods into the diagnostic pipeline addresses a critical barrier to clinical adoption by letting clinicians visualize which image features the AI model uses to reach its classification decisions, thereby supporting clinical trust and shared decision-making. More broadly, AI and machine learning methods have demonstrated diagnostic accuracies ranging from 81% to 97% for diabetic foot ulcer image and thermogram analysis, while prognostic models have achieved AUC values of 0.74 to 0.82 for risk assessment and outcome prediction. These capabilities suggest that AI tools can support not only initial diagnosis, but also longitudinal risk stratification and early identification of patients at risk for poor outcomes or amputation. Now let's look at AI versus manual wound measurement. Clinical validation of AI-enabled wound imaging applications has shown reliable performance in wound measurement tasks that traditionally require trained clinicians and significant time investment. A clinical validation study of the C4W, or Collabsure for Wounds, mobile application involving patients with diabetic foot ulcers, demonstrated that AI-derived wound area measurements correlated strongly with manual clinician measurements, supporting the use of smartphone-based AI tools as reliable alternatives to traditional wound measurement methods. The application provided objective, reproducible measurements that reduced inter-observer variability, which has been a persistent challenge in manual wound assessment. A systematic approach to clinical evaluation of AI-based digital wound assessment tools established a methodology for comparing AI-generated wound measurements against expert clinician assessment. This framework addressed a critical gap in the field: the absence of standardized evaluation protocols for validating AI wound measurement tools. The study found that AI tools produced measurements with acceptable agreement with clinician gold standards, supporting their use in clinical practice when appropriate validation has been performed. And here's a practical finding worth noting. AI tools achieved 92.2% quality images on the first attempt, compared with 75.7% for manual methods, showing that AI-assisted image capture produces higher quality documentation with fewer repeated attempts. Let's talk about wound segmentation, tissue classification, and mobile optimization. AI-based wound segmentation models have achieved clinically meaningful performance in delineating wound boundaries and classifying tissue types within the wound bed. Wound boundary segmentation models have achieved DICE scores of 92% and intersection over union scores of 85%, while tissue classification within wound beds yielded a mean DICE score of 78%. Though accuracy varied across tissue types, with particular challenges in differentiating fibrin from necrotic tissue. These models were optimized for mobile implementation through quantization techniques, achieving real-time inference with an average processing time of 0.3 seconds and only a 0.3% reduction in classification performance, making them practical for point-of-care use in outpatient, home care, and resource-limited settings. The C-Wound 2 model and Wound Viewer device represent platform-specific approaches to AI wound assessment across different wound types, including pressure injuries and venous leg ulcers. Accurate AI-based characterization of wound size and tissue composition in hard-to-heal wounds has been validated in clinical settings, showing that AI tools can provide consistent, objective tissue assessment that supports debridement, timing decisions, and treatment planning. The ability to standardize wound assessment across clinicians of varying experience levels represents a significant quality improvement opportunity, particularly in settings where wound care specialists aren't available. Now let's get into explainable AI and clinical trust building. The adoption of AI tools in clinical wound care depends critically on clinician trust, which in turn requires transparency in how AI systems arrive at their diagnostic conclusions. Explainable AI or XAI principles address this through visualization techniques that reveal the model's decision-making process. GradCam heat maps overlay the original wound image with color-coded regions, indicating the features most influential in the AI's classification, enabling clinicians to assess whether the model is attending to clinically relevant features. HAP values quantify the contribution of individual input features to the model's output, while LIME provides locally interpretable explanations for specific predictions. Research on clinician and patient perspectives on AI trust in wound care reveals that performance expectancy, the belief that AI will improve diagnostic accuracy and efficiency, emerges as the most consistent factor driving acceptance across care settings. Clinicians are more likely to accept AI tools positioned as a supportive second opinion rather than as autonomous decision makers. Patients tend to trust AI recommendations when mediated by their healthcare providers, suggesting that the clinician-AI patient relationship is a triadic interaction where clinician endorsement is essential. Both healthcare professionals and patients express limited understanding of AI principles, which highlights the need for education programs that build AI literacy alongside clinical skill development. Let's now examine multimodal data integration and predictive analytics. The evolution of AI wound assessment extends beyond image-based diagnostics to include multimodal data integration that combines wound imaging with patient demographics, laboratory values, comorbidity profiles, and treatment histories to generate clinical predictions. A systematic review of artificial intelligence methods for diagnostic and decision-making assistance in chronic wounds identified 3 primary AI application categories: wound classification and segmentation, healing prediction and prognosis, and treatment recommendation systems. The review found that while image-based AI tools have achieved the highest level of clinical validation, emerging applications that integrate patient-level data with wound characteristics show the potential to provide more personalized and accurate clinical decision support. Machine learning prognostic models for diabetic foot ulcer outcomes have demonstrated the capacity to identify patients at elevated risk for amputation or non-healing using combinations of clinical, laboratory, and imaging features. Random forest, gradient boosting, and deep learning architectures have achieved AUC values of 0.74 to 0.82 for risk assessment and outcome prediction, with models incorporating wound imaging data alongside patient demographics and comorbidity scores consistently outperforming those using either data source in isolation. These predictive capabilities have direct clinical implications for resource allocation, enabling wound care programs to identify high-risk patients who would benefit from intensive monitoring and early escalation of therapy while directing routine follow-up resources to patients with favorable prognostic profiles. Let's close this module by discussing time efficiency and documentation enhancement. Time motion studies provide hard evidence of the efficiency gains achievable through AI-assisted wound assessment. A comparative study of manual versus AI methods for wound assessment demonstrated that AI digital tools complete the assessment process in approximately 54% of the time required for manual evaluation methods. This efficiency gain covers image capture, wound measurement, tissue classification, and documentation, tasks that collectively take up a significant proportion of clinician time in wound care encounters. The time savings translate directly into increased clinical capacity, enabling clinicians to manage larger patient panels or allocate time to complex clinical decision-making that requires human judgment. AI-assisted documentation systems also enhance the completeness and consistency of wound records. In the Australian Health Service evaluation, implementation of an AI wound assessment application resulted in wound documentation improving significantly, with the proportion of encounters, including more than 2 documented wound characteristics, increasing from 24% to 70%. That improvement in documentation quality has downstream implications for care coordination, quality reporting, and outcomes tracking across healthcare systems. Now we're moving into Module 6, AI-driven treatment, telehealth, and remote monitoring. Beyond diagnostics, artificial intelligence systems are increasingly being applied to treatment planning, healing trajectory prediction, and clinical decision support in wound care. These applications combine wound imaging, patient demographics, laboratory values, comorbidity profiles, and microbiome analysis to generate treatment recommendations and forecast healing outcomes with growing accuracy. This module examines the evidence for AI-driven treatment planning, clinical outcomes from AI-assisted interventions, telehealth effectiveness for wound care delivery, implementation strategies, and considerations for special populations and health equity. Digital twin technology represents an emerging frontier in wound care decision support. By creating virtual representations of individual wounds, digital twin platforms simulate healing processes under various treatment scenarios, letting clinicians compare predicted outcomes before selecting interventions. AI-enabled wearable sensors interconnected with advanced wound dressings have demonstrated 94.6% accuracy in classifying healing stages, fast curing, slow curing, and no curing, using deep artificial neural network algorithms, providing continuous monitoring data that supports therapy adjustment decisions. Machine learning prognostic models for diabetic foot ulcer risk assessment have achieved AUC values of 0.74 to 0.82, offering moderate to high performance for identifying patients at risk for poor outcomes. A structural equation model incorporating wound microbiome composition, patient characteristics, and wound features explained 46% of variations in healing time, with the microbiome contributing the largest proportion of variance. This model included smoking status, wound volume, slough percentage, exudate characteristics, edema, percent granulation, and wound etiology, demonstrating that pulling together multiple data types substantially improves predictive accuracy beyond what wound imaging alone can achieve. Biomarker analysis has identified serum C-reactive protein, wound C-reactive protein, and wound monocyte chemoattractant protein 1 as significant predictors of healing, with receiver operating characteristic analysis demonstrating strong discriminative ability, an AUC of 0.863 for wound CRP and 0.830 for wound MCP1. Those are solid numbers. Let's now look at clinical outcomes from AI-assisted interventions. The most rigorous clinical outcome evidence comes from a randomized controlled trial evaluating the Ulcer Care AI-assisted clinical decision support system integrated with a telemedicine platform for chronic ulcer management in home care. Among 35 patients completing the study, 17 in the AI group and 18 in the control group, wound healing rates at 12 weeks were comparable between groups at 64.9% versus 73.4%, demonstrating non-inferiority of AI-supported care. But here's the clinically significant finding. The AI group required 58% fewer clinic visits, 5.5 plus or minus 2.6 versus 13.2 plus or minus 10.6. That's a substantial reduction in healthcare use without compromising healing outcomes. Caregiver quality of life showed greater improvement in the AI group as well, with the Family Dermatology Life Quality Index improvement at 10.3 plus or minus 5.0 versus 5.7 plus or minus 5.9, addressing the substantial burden that wound management places on informal caregivers in home settings. In a quasi-experimental study conducted across 4 clinical settings in an Australian health service, implementation of an AI wound assessment application resulted in 76.5% of wounds, 101 of 132, improving during the intervention period, with a mean wound size reduction of 53.99%. Wound documentation improved significantly, with the proportion of encounters documenting more than 2 wound characteristics increasing from 24% to 70%. Clinicians reported that the AI application provided instantaneous objective wound assessment, supported shared wound care plans, increased patient adherence to treatment protocols, and enhanced efficiency in providing virtual care while reducing patient travel time. Let's now examine telehealth effectiveness for wound care. Telehealth and telemedicine have become essential delivery models for wound care, accelerated by the COVID-19 pandemic, and supported by growing evidence demonstrating comparable outcomes to in-person care. A 2025 systematic review and meta-analysis of 22 randomized controlled trials evaluating telemedicine for chronic wound management found that telehealth interventions were associated with improved wound healing outcomes, reduced healthcare use, and high patient satisfaction across diverse wound types and care settings. The most commonly employed telehealth model was blended care, used in 87.7% of cases, integrating remote monitoring with scheduled in-person visits, followed by store and forward image transmission and real-time video consultation. A separate systematic review and meta-analysis of digital health interventions for chronic wound management confirmed that digital health technologies, including mobile applications, telemedicine platforms, and remote monitoring systems, improve wound-related outcomes and patient-reported outcomes compared with standard care. The reduction in clinic visits observed across multiple studies, from the 58% reduction in the randomized trial to significant travel time savings reported in the Australian evaluation, translates directly into cost savings and improved access for patients with mobility limitations, transportation barriers, or geographic isolation. Digital health interventions for chronic wound management have been further validated through a systematic review and meta-analysis examining the broader picture of digital health technologies, including mobile health applications, wearable sensors, remote monitoring platforms, and AI-integrated telemedicine systems. The review found that digital health technologies improve both wound-related clinical outcomes and patient-reported outcomes compared with standard care delivery models, with the strongest evidence supporting interventions that combine multiple digital health components, such as wound imaging, clinical decision support, and asynchronous communication with wound care specialists, into integrated platforms. The potential of these technologies to address healthcare access disparities is particularly significant for diabetic foot ulcer management, where a systematic review of digital health technologies identified substantial evidence gaps in implementation among underserved populations, low- and middle-income countries, and rural communities. Large language models represent an emerging frontier in AI-assisted wound care that goes beyond image analysis to encompass clinical documentation, patient education, and decision support. These models can generate structured wound assessment documentation from clinical notes, provide evidence-based responses to clinical queries about wound management, and support patient education through accessible language translation of complex medical concepts. However, the application of large language models in wound care remains in early stages, with significant questions about accuracy, bias, and appropriate clinical guardrails that need to be resolved before widespread adoption. The cost-effectiveness evidence, while promising, is still evolving. The significant reduction in clinic visits demonstrated in randomized trials has direct implications for healthcare cost reduction, and systematic reviews support the idea that AI-integrated telehealth can optimize wound care delivery and reduce unnecessary visits. However, formal cost-effectiveness analyses incorporating implementation costs, technology maintenance, training investment, and long-term outcome data are needed to establish definitive economic value. Let's now discuss implementation, training, workflow integration, and change management. Successfully implementing AI-assisted wound care in clinical practice requires attention to organizational readiness, structured training programs, adaptive workflow integration, and sound technical infrastructure. Healthcare professionals need competency development across 6 core domains to effectively integrate AI wound care tools: basic knowledge of AI and its healthcare applications, understanding of social and ethical implications including bias and health equity, skills for AI-enhanced clinical encounters, evidence-based evaluation of AI tool quality, workflow analysis to adapt to changing roles, and practice-based learning for continuous improvement. The Adaptive AI Engagement Framework provides a practical model for workflow integration, illustrating that clinicians should dynamically shift between Centaur strategies, meaning strategic task division with careful human validation of AI output, and cyborg strategies, meaning tightly integrated human-AI collaboration based on task stakes and time constraints. For high-stakes clinical decisions involving unvalidated tools, a Centaur approach with rigorous human oversight is essential. For validated wound measurement or lower-stakes documentation tasks, more integrated collaboration may be appropriate. Leadership engagement emerges as the most critical organizational factor, as healthcare leaders must recognize that AI deployment is a multi-year process requiring simultaneous attention to strategic vision, enabling factors, and operational implementation. Common barriers to implementation include concerns about increased workload during the learning curve, skepticism about AI accuracy, fear of professional deskilling, and limited understanding of AI principles among both clinicians and patients. Successful implementations address these barriers by providing protected time for training, establishing clinical champions who model effective use, demonstrating early wins through pilot projects, and maintaining iterative feedback loops that allow for workflow adjustments and technical modifications. Let's close this module by addressing special populations, health equity, and bias mitigation. AI-powered wound care tools offer particular promise for special populations who face barriers to accessing traditional specialist care. Rural and underserved communities benefit from mobile-first AI tools that operate on standard smartphones without requiring specialized hardware, with the multi-center proof-of-concept evaluation demonstrating that high diagnostic accuracy, 91.6% sensitivity, and 88.6% specificity is achievable on low-end devices. For rural Canadian communities, healthcare staff expressed confidence that AI-driven digital wound care solutions were superior to current practices for improving wound assessment accuracy, while emphasizing the need for context-sensitive implementation strategies. For elderly patients, implementation must address digital literacy barriers and concerns about technology replacing human connection, with training provided in multiple formats and family members included as technology intermediaries. For home care patients, AI tools must compensate for caregiver inexperience through intuitive interfaces, clear visual feedback, and automated alerts for deteriorating wounds. However, significant health equity concerns persist. AI models are often trained on datasets that underrepresent marginalized populations, potentially leading to biases that could worsen existing healthcare disparities. Training datasets must include diverse populations with representation across skin tones, geographic regions, and socioeconomic backgrounds to ensure AI accuracy across all patient populations. AI technologies have the potential to drive cost-effective, scalable, and equitable healthcare solutions by enabling resource-efficient tools deployable in low- and middle-income countries, mobile diagnostics, and lightweight algorithms that function on standard smartphones. Realizing this potential requires proactive attention to bias mitigation, regulatory framework development, and equitable access to digital infrastructure. Now we're moving into Module 7. Interprofessional wound care, nursing, physical therapy, and occupational therapy roles. Effective wound care is inherently interprofessional, requiring the coordinated expertise of nurses, physical therapists, occupational therapists, physicians, dietitians, and other allied health professionals working within collaborative practice frameworks. The complexity of chronic wound management, spanning assessment, prevention, direct wound care, rehabilitation, functional restoration, and care transitions, exceeds the scope of any single discipline. This module looks at the distinct contributions, evidence base, and clinical outcomes associated with nursing, physical therapy, and occupational therapy in wound care, with attention to setting specific delivery models and care coordination across the continuum. Let's start with nurse-led wound care, practices, outcomes, and certification. Nurses represent the largest workforce directly engaged in wound assessment and management across all care settings. Nurse-led wound care encompasses thorough wound assessment, evidence-based treatment selection, patient and caregiver education, care coordination, and quality monitoring. The evidence base for nurse-led wound care demonstrates significant clinical and economic advantages. A randomized controlled trial of specialized nurse-led care for chronic wounds during hospitalization and after discharge showed that patients receiving nurse-led care achieved statistically significant improvements in wound healing outcomes compared with standard care, with specialized nursing intervention associated with approximately quadrupled healing probability. That's a striking finding. The impact of nurse-led care extends to metabolic outcomes in diabetic patients with wounds. A randomized clinical trial found that nurse-led care for patients with diabetic foot ulcers improved both quality of care and levels of hemoglobin A1c, demonstrating that thorough nursing interventions address not only local wound factors but also systemic disease management that influences healing trajectories. The economic implications of nurse-led wound care models are substantial as well. A cost-effectiveness analysis of an innovative model of care for chronic wound patients demonstrated significant cost savings compared with standard care delivery models, supporting the economic viability of investing in specialized nursing wound care programs. Wound care certification confers measurable knowledge advantages that translate to improved clinical practice. A study examining the relationship between certification, education, and pressure ulcer knowledge in nursing found that certified wound care nurses demonstrated an 11 to 12.5 percentage point knowledge advantage over non-certified nurses on standardized assessment. This knowledge differential has direct implications for assessment accuracy, treatment selection, and patient outcomes, providing empirical support for institutional policies that encourage and support wound care certification for nursing staff. Now let's discuss physical therapy interventions and protocols in wound care. Physical therapists contribute distinct clinical expertise to wound care through interventions targeting tissue healing, functional mobility, rehabilitation, and prevention of wound-related disability. Physical therapy interventions in wound care encompass electrical stimulation, neuromuscular electrostimulation, scar management, early mobilization protocols, and exercise programs designed to enhance calf muscle pump function and peripheral circulation. Electrical stimulation, particularly high-voltage pulsed current, or HVPC, is the most extensively studied adjunct modality in physical therapy wound care. Unidirectional HVPC with the active electrode placed over the wound yields the greatest effect size, a standardized mean difference, or SMD, of 0.8. An SMD lets us compare results across studies that use different measurement tools. Think of it as a common yardstick. Generally, 0.2 is a small effect, 0.5 is moderate, and 0.8 or above is large. So an SMD of 0.8 for chronic wound healing is a large effect by any standard, with electrical stimulation demonstrating particular efficacy for pressure ulcers compared with venous or diabetic ulcers. A Cochrane review found that electrical stimulation probably increases the proportion of pressure ulcers healed and moderate certainty evidence, and the rate of healing with a mean difference of 4.59% per week. These findings support the inclusion of electrical stimulation as an evidence-based adjunct to standard wound care for pressure injuries. Neuromuscular electrostimulation, or NMEs, shows particular effectiveness as an adjunct to compression therapy in venous leg ulcer management. When combined with compression, NMEs achieved a healing rate of 0.56 mm per week versus 0.31 mm per week in controls, with mean time to wound closure of 40 days versus 77 days. Nearly cutting the healing time in half. These findings show that structured interventions enhancing calf muscle activity and venous pump function can significantly accelerate wound healing when combined with standard compression therapy. Physical therapists play a central role in scar management following surgical wounds and burns, employing manual therapy, silicone-based products, and pressure garments. Systematic review evidence demonstrates moderate to strong effects of physical scar management on pain, pruritus, pigmentation, pliability, surface area, and thickness of scar tissue. International practical guidelines recommend silicone sheeting or gel as the first-line prophylactic and treatment option, with pressure garments worn at least 16 to 23 hours per day at pressures exceeding 15 millimeters of mercury until scar maturation. In surgical populations, physical therapists are integral to enhanced recovery pathways, particularly in promoting early mobilization and return to functional independence. Systematic review evidence supports the benefit of early physical therapy interventions within enhanced recovery after surgery protocols on postoperative walking distance, achievement of activities of daily living, and reduced hospital length of stay, especially in colorectal and general surgical populations. Telerehabilitation in physical therapy practice is supported by a clinical practice guideline from the American Physical Therapy Association, which provides frameworks for delivering physical therapy services remotely, including wound-related rehabilitation, with particular relevance for patients in rural or underserved settings. Economic analysis demonstrates that virtual physical therapy care is associated with healthcare cost savings and reduced use compared with in-person delivery. Let's now discuss occupational therapy in wound assessment and acute wound care. Occupational therapy brings a unique perspective to wound care through its focus on functional performance, daily activities, and the interaction between wounds and occupational engagement. The American Occupational Therapy Association, or AOTA, recognizes wound care as within the scope of occupational therapy practice, with OT practitioners contributing to wound assessment, acute wound management, splinting and positioning, edema management, scar rehabilitation, and functional restoration. In acute care settings, occupational therapists contribute to wound management through thorough upper extremity assessment, custom splinting for wound protection and positioning, edema control techniques, and supporting functional independence during the wound healing period. For patients with burns, occupational therapy integration is essential for optimizing functional outcomes, with evidence from randomized controlled trials demonstrating that occupation-based interventions improve hand and upper extremity function, daily activities, and quality of life in patients with burn injuries. In emergency department settings, occupational therapy evidence supports early intervention for hand and upper extremity wounds, with systematic review data confirming the effectiveness of OT interventions for work-related injuries and musculoskeletal conditions of the forearm, wrist, and hand. Occupational therapists also manage the functional implications of comorbidities that affect wound healing. For patients with diabetes, OT practitioners address peripheral neuropathy through protective sensation education, adaptive footwear recommendations, and environmental modification to reduce injury risk. For patients with peripheral vascular disease, OT interventions focus on skin integrity maintenance, activity modification to support perfusion, and energy conservation strategies. For patients with malnutrition, OT addresses meal preparation adaptations and feeding assistance that support nutritional optimization. Scar management is a core occupational therapy competency, with OT practitioners employing silicone sheets, pressure garments, massage techniques, and functional activities to optimize scar pliability and minimize contracture formation. Edema management through elevation, compression, retrograde massage, and active range of motion exercises falls within the OT scope and directly supports wound healing by reducing tissue congestion and improving local circulation. Let's now look at technology-enabled interprofessional coordination. The integration of digital health technologies into interprofessional wound care creates new opportunities for coordinated care delivery that go beyond traditional setting-based boundaries. Mobile wound care applications that integrate clinical data across settings support interprofessional coordination by providing shared wound documentation accessible to all team members regardless of practice location. A cohort study examining the integration of factors associated with complex wound healing into a mobile application demonstrated that digital platforms can standardize wound assessment documentation, enable real-time communication among team members, and provide decision support algorithms that incorporate patient-specific prognostic factors. These platforms enable nursing, physical therapy, occupational therapy, and physician team members to access consistent wound data, review serial photographs and measurements, and coordinate treatment modifications without requiring in-person team meetings. The role of artificial intelligence in wound care education represents an emerging dimension of interprofessional practice development. A scoping review of AI applications in wound care education identified opportunities for simulation-based learning, automated feedback on wound assessment skills, and personalized learning pathways that adapt to individual clinician knowledge gaps. These educational applications have particular relevance for interprofessional training programs, where clinicians from different disciplines must develop shared competencies in wound assessment and management while maintaining discipline-specific expertise. The integration of AI-powered educational tools into continuing education curricula has the potential to standardize wound care knowledge across professions, reduce practice variability, and improve patient outcomes through more consistent application of evidence-based practices. Let's wrap up this module by discussing setting-specific delivery and care coordination. Wound care delivery models vary substantially across clinical settings, requiring adaptation of staffing models, intervention protocols, and care coordination strategies. In inpatient acute care, multidisciplinary wound teams support thorough assessment, advanced therapies, and coordinated discharge planning. In long-term care, prevention-focused programs with designated skin champions, systematic turning schedules, and nutritional support form the foundation of effective wound management. In home health settings, clear documented wound care plans, caregiver education, and regular monitoring enable early detection and intervention, with telehealth platforms extending specialist oversight to community-based patients. The transition between care settings is a particularly vulnerable period for wound patients. Nurse-led care during hospitalization and after discharge demonstrated that continuity of specialized wound nursing across the care transition improved healing outcomes compared with standard care. The American Heart Association emphasizes that reducing non-traumatic lower extremity amputations by 20% by 2030 will require coordinated interprofessional care delivery that bridges settings and disciplines. Mobile wound care applications that integrate clinical data across settings support this coordination by providing shared wound documentation accessible to all team members regardless of practice location. Now we're moving into Module 8, Integrative Case Studies. These case studies pull together knowledge from all preceding modules, challenging you to apply assessment strategies, evidence-based interventions, AI tools, and interprofessional coordination to realistic clinical scenarios. Let's start with Case Study 1, Diabetic Foot Ulcer with Peripheral Artery Disease. A 62-year-old male with type 2 diabetes mellitus and a hemoglobin A1C of 8.9%, chronic kidney disease stage 3 with an estimated glomerular filtration rate of 42 milliliters per minute, hypertension, and hyperlipidemia presents to a wound care clinic with a 3-week history of a non-healing plantar forefoot ulcer on the left foot. Physical examination reveals a 2.8 centimeter by 2.1 centimeter ulcer with a depth of 0.5 centimeters, a fibrinous base, moderate exudate, and no clinical signs of active infection. Pedal pulses are diminished bilaterally. Semmes-Weinstein monofilament testing confirms loss of protective sensation in both feet. The initial assessment proceeds with systematic application of validated tools. The Wi-Fi classification system stratifies this patient: wound grade 2 indicating a deep ulcer without bone or joint involvement, ischemia grade 2 with the ABI measured at 0.65, and monophasic Doppler signals in the dorsalis pedis and posterior tibial arteries, and foot infection grade 0 indicating no clinical signs of infection. The composite Wi-Fi score of 3 indicates an estimated 1-year major amputation risk of approximately 11%, classifying this as a moderate to high-risk presentation requiring urgent vascular evaluation. The ABI of 0.65 falls squarely within the range, indicating significant peripheral artery disease that's likely to impact wound healing potential. Given the evidence that delaying revascularization beyond 14 days is associated with a higher rate of major amputation, with an odds ratio of 3.1, the clinical team initiates an urgent vascular surgery referral. While awaiting vascular consultation, standard wound care begins with weekly sharp debridement, moisture-balanced dressings using hydrogel for the fibrinous base to promote autolytic debridement, and a non-removable knee-high offloading device to reduce plantar pressure by 80 to 90%. Glycemic management is optimized in coordination with endocrinology, with consideration given to the patient's SGLT2 inhibitor therapy. Canagliflozin is discontinued given the active foot ulcer and ischemic presentation, consistent with current recommendations. Nutritional assessment reveals albumin of 3.1 grams per deciliter, and targeted protein supplementation at 1.5 grams per kilogram per day, with micronutrient optimization is initiated, recognizing that patients with low albumin of 40 grams per liter or below, and poor limb perfusion, with an ABI below 1.0 derive particular benefit from nutritional intervention. The AI wound assessment application is deployed during the pre-revascularization phase to establish baseline wound documentation, capturing standardized images and measurements that will serve as the reference point for post-intervention healing trajectory analysis. The application achieves 92.2% quality images on the first attempt, compared with 75.7% for manual methods, ensuring reliable baseline data. The Interprofessional team applies the ABCDFGI systematic approach to ensure thorough wound assessment that covers all clinically relevant domains. Given the patient's chronic kidney disease stage 3 and diabetes, quarterly foot screening is recommended per IWGDF guidelines for high-risk Category 3 patients, with monthly foot examinations shown to reduce major amputation rates by 17% in dialysis populations. Following successful endovascular revascularization at day 10, the patient enters a post-revascularization wound management phase with AI-assisted monitoring. The wound care team uses a smartphone-based AI wound assessment application to perform standardized wound measurements at each visit, documenting wound area, tissue composition, and healing trajectory with objective, reproducible data. The AI application completes assessment in approximately 54% of the time required for manual methods, freeing clinician time for complex clinical decision-making. At 4 weeks post-revascularization, the wound demonstrates a 40% reduction in area, meeting the threshold for adequate healing progression. Interprofessional coordination between wound care nursing, vascular surgery, endocrinology, nephrology, and physical therapy ensures thorough management of this complex presentation. Now let's move to case study 2, stage 3 pressure injury in an elderly nursing home resident. An 82-year-old female with congestive heart failure at NYHA Class 3 type 2 diabetes mellitus, moderate malnutrition with an albumin of 2.8 grams per deciliter and a BMI of 19.2, and limited mobility presents with a stage 3 sacral pressure injury measuring 5.2 centimeters by 4.8 centimeters with partial thickness tissue loss extending into subcutaneous fat, moderate serous exudate, and 40% granulation tissue at the wound base. The patient resides in a long-term care facility and spends the majority of her day in a wheelchair. Braden scale assessment yields a score of 13 indicating high risk, with subscale deficits in mobility, activity, nutrition, and moisture. The PUSH 3.0 score is calculated at initial evaluation and will be tracked serially to monitor healing trajectory. A full prevention bundle is implemented based on international consensus recommendations. risk reassessment every 8 hours, repositioning every 2 hours with a documented turning schedule, an active alternating pressure mattress for bed, and a pressure redistributing wheelchair cushion, preventative dressings at the sacrum and heels, a moisture management plan for incontinence using disposable barrier products and nutritional supplements. Nutritional optimization is a critical priority given this patient's malnourished state. The subjective global assessment confirms moderate malnutrition, a factor independently associated with non-healing, carrying a relative risk of 1.84. A targeted nutritional plan sets 1.5 grams per kilogram per day of protein supplementation with calorie-dense oral nutritional supplements, supplemented with vitamin C, zinc, and iron based on laboratory assessment. The dietitian coordinates with nursing to ensure adequate caloric intake and monitors albumin levels bi-weekly as a surrogate marker of nutritional status. Local wound care follows the time framework, with autolytic debridement supported by a hydrogel-impregnated gauze for the fibrinous component and a foam dressing for exudate management. A specialized wound care nurse leads the management team, consistent with evidence that nurse-led care approximately quadruples healing probability compared with standard care. Nurse-led management includes thorough wound assessment at each dressing change, serial push 3.0 scoring, patient and staff education on pressure injury prevention, and coordination with the facility wound care committee. Telehealth consultation with a wound care specialist is established for monthly wound review via store and forward image transmission, enabling specialist oversight without requiring patient transfer from the facility. The occupational therapist addresses the patient's functional independence during wound recovery, assessing her ability to perform wheelchair-to-bed transfers safely without disrupting the wound care regimen, and recommending adaptive equipment, including a pressure redistributing wheelchair cushion and modified positioning devices that accommodate both wound protection and functional activity. The wound care team uses the AI wound assessment application for serial documentation, generating objective wound measurements and tissue classification data at each dressing change that are shared electronically with the consulting wound specialist via the telehealth platform. This digital coordination ensures that all team members, nursing, dietitian, physical therapy, occupational therapy, and the remote wound specialist, access consistent standardized wound data for collaborative decision-making. At 8 weeks, the wound demonstrates a 55% reduction in surface area, a favorable push 3.0 trajectory, and increasing granulation tissue, confirming the effectiveness of this interprofessional approach. The patient's albumin has improved to 3.3 grams per deciliter with sustained nutritional intervention. The American Heart Association policy statement emphasizing the goal of reducing non-traumatic lower extremity amputations by 20% by 2030 really drives home the critical importance of this type of coordinated, interprofessional wound care that addresses prevention, assessment, treatment, and rehabilitation simultaneously. Now let's look at case study 3, recalcitrant venous leg ulcer in an obese patient. A 58-year-old female with a BMI of 38, a history of deep venous thrombosis 5 years prior, chronic venous insufficiency with bilateral lower extremity edema and hypertension presents with a medial malleolar venous leg ulcer present for 5 months with minimal healing progress despite standard compression therapy. The ulcer measures 6.4 centimeters by 4.2 centimeters with a shallow, predominantly fibrinous base and moderate exudate. The patient reports difficulty tolerating 4-layer compression bandaging and inconsistent adherence. Ankle brachial index measurement yields a value of 0.92 bilaterally, confirming adequate arterial perfusion and safety of compression therapy. However, the 5-month duration, large wound area exceeding the equivalent of 8.25 square centimeters, and presence of fibrin coverage exceeding 50% of the wound surface all represent independent predictors of delayed healing. The ABI of 0.92 rules out significant arterial disease, but the combination of obesity, ulcer chronicity, and large wound area means we need to escalate beyond standard compression alone. Given evidence that early endovenous ablation combined with compression improves healing compared with compression alone, with a hazard ratio for time to healing of 1.41, duplex ultrasonography is performed and reveals significant superficial venous incompetence in the great saphenous vein. Referral for endovenous ablation is initiated. Adjunctive pharmacotherapy with pentoxifylline 400 mg 3 times daily is started, based on meta-analysis evidence demonstrating improved healing when combined with compression, with a risk ratio of 1.56 versus placebo plus compression. Compression therapy is modified to address the patient's obesity-related adherence challenges. A transition from 4-layer bandaging to a 2-layer Velcro inelastic compression system improves comfort and self-application capability, recognizing that Velcro inelastic compression has demonstrated comparable efficacy to 3- or 4-layer systems. An AI wound assessment application is implemented for documentation and remote monitoring, enabling the wound care team to review wound images and measurements between clinic visits and reduce the frequency of in-person visits from weekly to bi-weekly, consistent with evidence that AI-supported telehealth care achieves equivalent healing outcomes with significantly fewer clinic visits. A structured exercise program targeting calf muscle pump enhancement is prescribed, based on evidence that neuromuscular electrostimulation combined with compression achieves significantly faster healing rates. Physical therapy intervention incorporates both exercise prescription and neuromuscular electrostimulation to enhance calf muscle pump function. The physiological rationale is well established. The calf muscle pump serves as the primary mechanism for venous return from the lower extremities, and impaired calf muscle function contributes to sustained venous hypertension that perpetuates the pathophysiological cascade underlying venous ulceration. A structured exercise program targeting ankle dorsiflexion, plantar flexion, and walking endurance is prescribed, with evidence supporting that structured exercise combined with compression therapy improves both wound healing and functional capacity in patients with venous leg ulcers. The occupational therapist addresses barriers to compression adherence, including difficulty with application technique due to the patient's body habitus, by providing instruction in self-application of the Velcro compression system and recommending adaptive tools for independent donning and doffing. At 12 weeks following endovenous ablation and the multimodal treatment approach, the wound demonstrates a 65% reduction in area with predominant granulation tissue at the wound base and active epithelialization at the wound margins. Let's now look at Case Study 4, Postoperative Surgical Wound in an Immunosuppressed Patient. A 47-year-old male renal transplant recipient on tacrolimus and prednisone presents with a surgical site infection of the midline abdominal incision following elective cholecystectomy, diagnosed 8 days postoperatively. The wound shows erythema extending 3 cm beyond the incision margin, purulent drainage, wound dehiscence over a 4 cm segment, and tenderness on palpation. The patient has chronic kidney disease stage 4 with an estimated glomerular filtration rate of 22 milliliters per minute, a BMI of 32, and a hemoglobin A1C of 7.2%. Retrospective analysis identifies modifiable risk factors that were addressed perioperatively. Perioperative glycemic control maintained blood glucose below 200 mg per deciliter, chlorhexidine alcohol skin preparation was used, normothermia was maintained intraoperatively, and appropriate antibiotic prophylaxis was administered per WHO guidelines. However, the patient's immunosuppressed state from chronic prednisone and tacrolimus, obesity, and chronic kidney disease represent non-modifiable risk factors that substantially increase surgical site infection risk. The dose-dependent relationship between obesity and SSI risk, with Class 1 obesity at a BMI of 30 to 34.9, carrying an odds ratio of 1.5 for SSI and colorectal surgery, applies to this patient's abdominal procedure. Wound management involves surgical consultation for wound opening, irrigation, and packing. Negative pressure wound therapy is considered for the dehisced segment, with the decision informed by evidence that in vascular and high-risk surgical populations, NPWT significantly reduces major wound complications. Coordination with the transplant team addresses immunosuppression management, with consideration of temporary dose reduction balanced against rejection risk. Corticosteroids and mTOR inhibitors most consistently demonstrate detrimental effects on wound healing. Chronic kidney disease management is coordinated with nephrology, recognizing that CKD substantially impairs wound healing through uremic toxins, vitamin deficiencies, and compromised angiogenesis. Early mobilization starts within 24 hours, with physical therapy implementing an ERAS-aligned protocol targeting post-operative walking distance and activities of daily living. Occupational therapy addresses functional independence during wound recovery, including adaptive strategies for abdominal wound protection during transfers, toileting, and dressing activities. AI-assisted wound documentation provides standardized objective measurements of wound dimensions and tissue composition at each dressing change, enabling the multidisciplinary team to track healing trajectory and identify early signs of complication. This patient starkly illustrates the effect of comorbidities on wound healing. He carries immunosuppression, obesity, chronic kidney disease, and diabetes simultaneously, a constellation of risk factors that substantially reduces healing probability and increases the risk of wound complications. Each comorbidity independently impairs one or more phases of the wound healing cascade. Immunosuppression blunts the inflammatory and proliferative responses. Obesity creates chronic inflammation and tissue hypoxia. Chronic kidney disease impairs angiogenesis and growth factor signaling, and diabetes disrupts cellular migration and extracellular matrix formation. The cumulative effect is a wound healing environment that requires intensive, coordinated intervention across multiple clinical domains simultaneously. The patient is discharged to home health at day 14 with a coordinated transition plan. Home health nursing provides wound care 3 times weekly, with AI-enabled telehealth consultation with the surgical and wound care teams bi-weekly. The patient's healing trajectory is monitored remotely through the AI application, with automated alerts configured for wound area increase, new purulence, or expanding erythema. At 6 weeks, the wound demonstrates progressive granulation and contraction, with plans for secondary closure assessment at 8 weeks. Now let's discuss Case Study 5, Infected Diabetic Foot Ulcer with Suspected Osteomyelitis. A 71-year-old female with a 22-year history of type 2 diabetes mellitus and a hemoglobin A1C of 9.4%, peripheral neuropathy, hypertension, and hyperlipidemia, presents to the emergency department with a 4-day history of increasing erythema, warmth, and purulent drainage from a plantar first metatarsal head ulcer on the right foot. The ulcer has been present for approximately 6 weeks and was initially managed with weekly dressing changes by a home health nurse. The patient reports no pain due to dense peripheral neuropathy, confirmed by absent protective sensation on Semmes-Weinstein monofilament testing bilaterally. Physical examination reveals a 3.2 cm by 2.6 cm ulcer with a depth of 1.2 cm, necrotic base with purulent exudate, erythema extending 4 cm beyond the wound margin, and local warmth. The probe-to-bone test is positive, with a metallic instrument passing through the wound to contact bone at the first metatarsal head. The 2023 guidelines from the International Working Group on the Diabetic Foot and the Infectious Diseases Society of America classify this wound as a moderate infection, grade 3, given the cellulitis extending more than 2 cm beyond the wound edge in the absence of systemic inflammatory response syndrome criteria. The positive probe-to-bone test, combined with an erythrocyte sedimentation rate of 82 mm per hour, substantially raises the pretest probability of osteomyelitis. Remember, an ESR greater than 70 mm per hour improves diagnostic accuracy for osteomyelitis substantially, with a likelihood ratio of 11, and the combination of a positive probe-to-bone test with plain film radiography demonstrating cortical erosion at the first metatarsal head can be sufficient for diagnosis in hospitalized patients, with a likelihood ratio of 14. Wi-Fi classification is performed. Wound grade 3 indicating a deep ulcer with bone involvement, ischemia grade 1 with an ABI measured at 0.88, and biphasic Doppler signals bilaterally confirming adequate arterial perfusion, and foot infection grade 3 indicating moderate infection. The composite Wi-Fi score of 4 indicates an estimated 1-year major amputation risk of approximately 38%. That's a number that warrants aggressive multidisciplinary intervention. Inpatient management begins with empiric intravenous broad-spectrum antibiotics covering gram-positive co-CEI, gram-negative bacilli, and anaerobes, pending wound culture results. Blood glucose management follows the ADA 2026 standards of care for inpatient settings, with a continuous insulin infusion protocol targeting blood glucose maintenance between 100 and 180 mg per deciliter throughout the acute treatment phase. The persistent unresolved inflammation characteristic of the diabetic wound environment, driven by hyperglycemia-mediated cellular dysfunction, defective white cell function, and biofilm involvement, demands aggressive infection control alongside metabolic optimization. Surgical debridement is performed on hospital day 2, with sharp excision of all necrotic tissue, wound bed curettage, and bone biopsy for histopathological confirmation of osteomyelitis. Culture results reveal methicillin-sensitive Staphylococcus aureus and Enterobacter cloacae, and antibiotics are narrowed accordingly. Nutritional assessment using the subjective global assessment reveals mild to moderate malnutrition with albumin of 3.0 grams per deciliter and prealbumin of 12 milligrams per deciliter. A targeted nutritional plan is implemented with protein intake of 1.5 grams per kilogram per day. Oral nutritional supplements enriched with arginine, glutamine, and hydroxymethylbutyrate and micronutrient supplementation including vitamin C and zinc. This approach is supported by evidence that patients with low albumin of 40 grams per liter or below derive particular benefit from targeted amino acid supplementation, with patients 1.70 times more likely to heal compared with controls. The patient's medication regimen is reviewed with endocrinology. Her existing metformin and glipizide regimen is supplemented with semaglutide, a GLP-1 receptor agonist that has demonstrated benefits independent of baseline diabetes duration, hemoglobin, A1C levels, body mass index, or concomitant therapy. No SGLT2 inhibitors are initiated given the active foot ulcer with bone involvement, consistent with the precautionary recommendation to avoid canagliflozin in patients with significant lower limb complications. Wound management following surgical debridement transitions to negative pressure wound therapy for the deep wound cavity, based on evidence that NPWT is particularly effective for deep and postoperative wounds, with a meta-analysis of 943 patients from 9 randomized clinical trials, demonstrating improved healing compared with moist wound healing, with an odds ratio of 3.6. The wound care nurse initiates AI-assisted wound documentation using a smartphone-based application to capture standardized baseline images and measurements post-debridement. The AI application generates objective wound area, depth, and tissue classification data that will be tracked serially throughout the 6-week antibiotic course and beyond, enabling the treatment team to identify healing trajectory deviations that might indicate inadequate source control or treatment failure. The DFU-XI framework's explainability features, including GradCam heat maps and SHAP values, provide the wound care team with visual confirmation that the AI assessment is attending to clinically relevant wound features, supporting clinical trust in the technology. The patient is discharged on hospital day 7 with a peripherally inserted central catheter for 6 weeks of intravenous antibiotics. A non-removable knee-high offloading device is fitted to reduce plantar pressure at the ulcer site by 80 to 90%. Home health nursing provides wound care 3 times weekly with NPWT management and dressing changes. Telehealth wound consultation is established bi-weekly, with the AI wound assessment application enabling the home health nurse to capture and transmit standardized wound images that the wound care specialist reviews remotely. The physical therapist develops a home exercise program targeting ankle mobility and gait training within the constraints of the offloading device, while the occupational therapist provides instruction in protective footwear use, daily foot inspection techniques adapted for a patient with dense neuropathy using a mirror in caregiver, assisted inspection, and environmental modification to reduce fall risk. At 12 weeks, the wound has decreased to 1.1 centimeters by 0.8 centimeters with a granulating base. Inflammatory markers have normalized, and bone biopsy culture-directed antibiotic therapy has been completed. The interprofessional team coordinates transition to a therapeutic footwear program and quarterly foot screening as recommended for high-risk Category 3 patients. Thank you for completing this continuing education course. Your dedication to advancing your skills in wound care makes a real difference for your patients. We will now review the exam questions to solidify your understanding of wound care assessment and management, with a focus on integrating AI tools into clinical practice. For each question, I will read the question aloud, identify the correct answer, and then provide a rationale explaining why that answer is correct. Let's get started. Question 1. Which validated classification system integrates wound severity, ischemia grade, and foot infection status to predict 1-year major amputation risk in patients with diabetic foot ulcers? The correct answer is C, Wi-Fi, which stands for wound, ischemia, and foot infection. Rationale. The Wi-Fi classification system was developed by the Society for Vascular Surgery, specifically to stratify amputation risk in patients with threatened limbs. It assigns grades across 3 domains: wound extent, degree of ischemia, and severity of foot infection. Each domain is scored from 0 to 3, and the composite score has been independently validated to correlate with 1-year major amputation rates, ranging from approximately 0% for the lowest scores up to 38% for the highest. This makes Wi-Fi uniquely suited for predicting amputation risk because it captures the interplay among tissue loss, blood supply, and infection, which together drive limb-threatening outcomes. Other tools like Push 3.0, Sinbad, and the Braden scale serve different purposes entirely, such as tracking healing progress, classifying ulcer features, or predicting pressure injury risk. Question 2. What 3 parameters does the pressure ulcer scale for healing, known as Push 3.0, evaluate to monitor healing progress in existing pressure injuries? The correct answer is B, wound size, exudate amount, and tissue type. Rationale. Push 3.0 was developed by the National Pressure Injury Advisory Panel as a concise, validated instrument for serial wound monitoring. It scores 3 specific parameters. First, wound size is measured as the greatest length multiplied by the greatest perpendicular width. Second, exudate amount is categorized as none, light, moderate, or heavy. Third, tissue type is classified across a spectrum from closed or epithelial tissue to necrotic tissue. These 3 subscores are summed to produce a composite score ranging from 0 to 17, where 0 indicates a healed wound. By tracking changes in this composite score over time, clinicians can objectively determine whether a pressure injury is improving, stagnating, or deteriorating. The other answer choices reference parameters from different assessment frameworks, such as the Braden scale or general clinical signs of infection, none of which are part of the Push 3.0 scoring system. Question 3. Which of the following is considered the single most important intervention for plantar diabetic foot ulcers? The correct answer is A, offloading with knee-high non-removable devices. Rationale. International guidelines, including those from the International Working Group on the Diabetic Foot, consistently identify offloading as the cornerstone intervention for plantar diabetic foot ulcers. The underlying principle is straightforward. Sustained mechanical pressure on the ulcer bed disrupts tissue repair and perpetuates the wound. Knee-high non-removable devices, which include total contact casts and prefabricated walkers rendered irremovable with a cohesive bandage or cast material, are the preferred modality because they reduce plantar pressure by 80 to 90% compared with standard footwear. Critically, making the device non-removable addresses the well-documented problem of patient non-adherence, since studies show patients wear removable devices far less than prescribed. While debridement, infection management, and adjunctive therapies like hyperbaric oxygen all play important roles in comprehensive wound care, none of them can compensate for ongoing mechanical trauma to the wound. This is why offloading is considered the single most important intervention. Question 4. A Cochrane systematic review found that compression therapy for venous leg ulcers probably shortens time to complete healing with a pooled hazard ratio of 2.17. What ankle brachial index threshold is generally considered safe for initiating full compression therapy? The correct answer is D, an ABI greater than 0.8 or 0.9. Rationale. Before initiating compression therapy for venous leg ulcers, clinicians must rule out significant peripheral arterial disease because applying external compression to limbs with compromised arterial supply can cause tissue ischemia and necrosis. The ankle brachial index is the standard screening tool for this purpose. An ABI above 0.8 to 0.9 indicates adequate arterial perfusion to safely tolerate full therapeutic compression, typically 30 to 40 millimeters of mercury at the ankle. When the ABI falls between 0.5 and 0.8, the patient may still benefit from compression, but it must be modified, usually reduced to lighter pressures and applied under close specialist supervision. Below 0.5, compression is generally contraindicated because the arterial supply is too compromised. The slight variation between the 0.8 and 0.9 thresholds reflects differences across clinical guidelines, but the key takeaway is that a thorough vascular assessment with ABI measurement is an essential safety step before starting any compression regimen. Question 5. Which dressing type is most appropriate for heavily exudating wounds due to its high absorptive capacity while maintaining moisture balance at the wound dressing interface? The correct answer is A, alginates and hydrofibers. Rationale. Managing exudate is one of the central challenges in wound care, and dressing selection must match the wound's moisture profile. Alginates are derived from seaweed-based calcium alginate fibers, and hydrofibers are composed of sodium carboxymethyl cellulose. Both materials share a key property. They absorb large volumes of wound fluid and transform into a soft, cohesive gel upon contact with exudate. This gelling action locks moisture within the dressing while maintaining an optimal moist environment at the wound surface, which is essential for cellular migration, autolytic debridement, and granulation tissue formation. For heavily exudating wounds, this high absorptive capacity prevents maceration of the surrounding skin while avoiding the opposite problem of wound desiccation. By contrast, hydrogels donate moisture and are designed for dry wounds. Film dressings are thin and minimally absorptive, and hydrocolloids are best suited for light to moderate exudate levels. Question 6. What is the recommended optimal daily protein intake range for patients with chronic wounds? The correct answer is D, 1.25 to 1.5 grams per kilogram of body weight. Rationale. Wound healing is a metabolically demanding process that significantly increases the body's protein requirements. Protein provides the amino acids necessary for collagen synthesis, immune cell function, and angiogenesis, all of which are critical to tissue repair. The general recommended dietary allowance for healthy adults is approximately 0.8 grams per kilogram per day, but this is insufficient for patients with chronic wounds. Clinical nutrition guidelines recommend 1.25 to 1.5 grams per kilogram per day as the optimal range for most patients with chronic wounds. This range supports the increased demands of the proliferative and remodeling phases of healing without imposing excessive renal load in the general wound care population. For patients with pressure injuries, particularly those with significant exudate losses that deplete protein reserves, even higher intakes may be warranted and should be individualized. Inadequate protein intake is a modifiable risk factor for impaired healing, which is why nutritional screening and supplementation are integral components of evidence-based wound management. Question 7. Through which primary mechanism does obesity impair wound closure at the vascular level? The correct answer is B, reduced endothelial progenitor cell function with impaired adhesion, migration, and proliferation. Rationale. Obesity creates a chronic, low-grade inflammatory state that disrupts multiple wound healing pathways, but at the vascular level, the primary mechanism involves endothelial progenitor cells. These progenitor cells are normally recruited from the bone marrow to sites of tissue injury, where they contribute to new blood vessel formation, a process known as vasculogenesis. Research has demonstrated that endothelial progenitor cells isolated from obese individuals exhibit significantly impaired adhesion, migration, and proliferation compared with cells from non-obese subjects. This dysfunction means that the formation of new microvasculature in the wound bed is compromised, resulting in inadequate oxygen and nutrient delivery to healing tissues. The adipose tissue itself contributes to this problem by secreting pro-inflammatory cytokines and adipokines that further impair progenitor cell mobilization and function. This vasculogenic impairment is distinct from other obesity-related wound healing problems, such as hypoperfusion of subcutaneous adipose tissue, increased wound tension, and altered immune responses, but it represents the primary vascular level mechanism. Question 8. In a multi-center proof-of-concept clinical evaluation, what sensitivity and specificity did an AI system deployed on a low-end smartphone achieve for automated diabetic foot ulcer detection? The correct answer is C, a sensitivity of 91.6% and a specificity of 88.6%. Rationale. This question refers to a landmark study that evaluated the real-world feasibility of using artificial intelligence for diabetic foot ulcer screening in resource-limited settings. The study enrolled 81 patients across multiple clinical sites and analyzed 203-foot photographs captured using a low-end smartphone, which is a critical detail because it demonstrates that advanced AI diagnostics do not necessarily require expensive hardware. The AI system achieved a sensitivity of 91.6%, meaning it correctly identified the vast majority of ulcers that were present, and a specificity of 88.6%, meaning it correctly identified most feet without ulcers. After algorithmic refinement, the specificity improved further to 92.4%. These performance metrics are significant because early detection of diabetic foot ulcers is strongly associated with improved outcomes and reduced amputation rates. An AI tool that performs at this level on accessible hardware has the potential to expand screening capacity, particularly in primary care and community settings where wound care specialists may not be readily available. Question 9. In the randomized controlled trial evaluating the Ulcer Care AI-assisted clinical decision support system, what was the most clinically significant finding regarding healthcare utilization? The correct answer is C. The AI group required 58% fewer clinic visits with comparable healing rates. Rationale. This randomized controlled trial represents some of the strongest evidence to date for AI-assisted wound management. The study compared patients whose care was guided by the UlcerCare AI clinical decision support system against a control group receiving standard care. The most striking finding was that the AI-supported group required only 5.5 clinic visits on average, compared with 13.2 visits in the control group, a 58% reduction that was statistically significant with a p-value of 0.009. Importantly, this dramatic reduction in healthcare utilization did not come at the cost of clinical outcomes. Wound healing rates at 12 weeks were comparable between groups, 64.9% in the AI group versus 73.4% in the control group, with a p-value of 0.88 demonstrating non-inferiority. This finding is clinically significant because it suggests that AI-guided care can maintain equivalent healing outcomes while substantially reducing the burden on both patients and healthcare systems. Fewer clinic visits translate to lower costs, reduced patient travel burden, and more efficient allocation of specialist time. Question 10. In Case Study 1, a 62-year-old male with a diabetic foot ulcer has an ABI of 0.65 and a Wi-Fi composite score of 3. Based on these findings, what is the most appropriate immediate clinical action? The correct answer is D. Initiate urgent vascular surgery referral while beginning standard wound care. Rationale. This case presents a patient with two alarming findings that together demand urgent action. First, the ABI of 0.65 indicates significant peripheral arterial disease, meaning blood flow to the affected limb is substantially compromised. Second, the Wi-Fi composite score of 3 corresponds to an estimated 1-year major amputation risk of approximately 11%. Evidence from vascular surgery literature demonstrates that delaying revascularization beyond 14 days is associated with a significantly higher rate of major amputation, with an odds ratio of 3.1. This means time is of the essence. The correct approach is a dual-track strategy. Initiate an urgent vascular surgery referral to evaluate the patient for revascularization while simultaneously beginning standard wound care, including appropriate debridement, offloading, and moisture management. Full compression therapy is contraindicated at this ABI level because it could further compromise an already impaired arterial supply. Hyperbaric oxygen therapy, while potentially beneficial as an adjunct, does not address the underlying vascular insufficiency. And simply discharging the patient with basic wound care instructions would ignore the high amputation risk and the urgent need for revascularization. That concludes our review of the exam questions for wound care assessment and management, integrating AI tools into clinical practice. Remember to focus on the key clinical decision-making frameworks we covered, including the Wi-Fi classification system, ABI thresholds for compression safety, evidence-based dressing selection, and the emerging role of AI in optimizing wound care delivery. Good luck on your exam!